All right. So basically, this is just for the exam coming up on Tuesday. I think that we've recorded a lot of stuff for you guys, and on the pre-recorded lectures. I believe everything you need to know for the exam on Tuesday has been there. If you watch those pre-recorded lectures, the review sessions, the case walk-up, everything, I think you're ready for this exam. So what I want to do today is just kind of go over things that I think is very, very important that I think you guys might still be struggling with, to make sure we're on the same page. Just see something, and
Recording stopped.
let me do it again.
Recording in
Okay.
progress.
So one of the things I wanted to go over real quick. Now my thing's acting up. So one of the things I want to go over today is this concept right here. Do you guys have any issue with this concept when it comes to the hardening of the arterial wall? There are different types. The atherosclerosis, meaning hardening of the wall, the different types of it. Do you guys have any issue with this concept? So I want you to unmute and just talk to me, so it could be a interactive session.
It doesn't seem too complicated, this slide.
Okay, so again, we discussed this. So when it comes to your atherosclerosis, pretty much just means that there is fat deposit within the lumen. Okay, and once that happens, okay, you get narrowing of the vessel. Okay, so when it comes to atherosclerosis, the big difference here is it's not same thing as atherosclerosis. It's different. It's called atherosclerosis. With atherosclerosis, basically you have protein deposit and also hyperplasia of the muscle within the lumen. Okay, the main thing I think you guys should know here is which vessel is really being affected. With atherosclerosis, fatty deposit is the large or the medium arteries. When it comes to atherosclerosis, is the small and the arterioles. And when it comes to the Mockenbach, is the small and medium. So basically, that's what you have to know here. We discussed it multiple times, so I won't go into depth about that. This is just kind of going over it again. Atherosclerosis, hardening of the vessel. When it comes to the atherosclerosis, fatty deposit, large and medium vessel, and affects the intima. When it comes to medial calcific, affects the media. And when it comes to the atherosclerosis, which is proliferation of the muscle within a vessel, and also iodine protein deposits, you get the atherosclerosis, which affects the small vessels, okay, and arterioles. That you should know very well. All right. So when it comes to a patient that's got a PAD, for every 1% of increase in A1C, what's the chances of those people developing PAD? Anybody know?
28%.
28%. That is very important. I don't believe in statistics and whatnot, but there's some things that are very important, especially anything that has to do with diabetes and PAD. That's what we do in podiatry. So you should know everything about that, including the statistics. So you should know those numbers. Okay. Anyway, acute and curriculum ischemia. Okay, you guys know that already, but the most important thing is with acute ischemia, on the exams, on board exams, what you're looking for is there any sudden onset of pain. So these people will have pain that happens within hours, within days, but less than 2 weeks, whereby curriculum ischemia is more than 2 weeks. You need to know the 6 P's. You need to know your acute ischemia is emergency, whereby when it comes to your critical ischemia, you have to know pretty much your 4 things that will give it away. For example, rest pain or night pain, non-healing ulcers, gangrenous changes, or could be ischemic changes. Okay, when a patient's got a positive Burgers test, okay, that is also your critical ischemia. So you should know that. Okay, another thing that is important is, and I'm going fast because I think we went in depth about this. I want to focus a little more on edema. I want to focus a little more on Charcot. So I'm just rushing through this and going over things that I think is really important that I think we went over already, but just kind of to make sure you guys focus a little more on that. When you trace a vessel, from proximal to distal, and you notice that the vessel is completely gone as you're going distally, and you can't find it anymore, there's no reconstitution, that means that you have an ALI. So you should know that very well. Now, to ALI, can you guys tell me what are the medical treatments for ALI? Just shout it out. Let's talk about it. Go ahead, anyone?
Anticoagulants.
Anticoagulant, keep going.
Don't you do like an IV fluid bolus?
IV fluid bolus, thank you. Keep going. Do you want to raise that lip up or down?
Raise. You don't want to raise it. You want to keep it down.
You want to keep it down, okay? What else? Do you want to give him some kind of bicarbonate, and why?
Yes, because of lactic acidosis.
That's right. So can you give me 4 different conditions that could, by the way, you have to remember, when it comes to acute ischemia and compartment syndrome, both of them will lead to rhabdomyolysis, okay? And this rhabdo is what's really causing emergencies, right? That's what's causing that's what's really causing increased production of myoglobin to the kidney, causing acute renal failure. So acute ischemia, compartment syndrome will lead to rhabdomyolysis. What other conditions that we talked about that could lead to increased production of rhabdomyolysis?
Compartment syndrome.
Compartment syndrome, okay. Give me 4. So compartment syndrome.
Can it be statin induced?
I mean, I guess the question, what I'm trying to say here is, okay, what are conditions that could lead to compartment syndrome? Okay, let me just put it like that. Give me 4 conditions that could lead to compartment syndrome.
Trauma.
Okay, what's a trauma? Okay.
ALI.
Acute limb ischemia, thank you. Acute limb ischemia will lead to, compartment syndrome. Okay. Compartment syndrome, from trauma will also to compartment syndrome, right? What's number 3?
Revascularization.
Revascularization of a patient that's got a complete occlusion, meaning that a patient that's got acute limb ischemia, after revascularize those patients, they could develop compartment syndrome also. So that's true. Keep going.
Necrotizing fasciitis, maybe?
Absolutely. You're 100% correct. Infection, especially your mainly your gas gangrene. So let me explain why that is. Okay. If you look in your foot, how many compartments do we have in the foot? Anybody know? I mean, this is not going to be an exam. I'm just asking, just from surgery. You got just came from surgery.
9 or 10?
Yeah, some people say 9, some people say 10. That's fine. So when you have necrotizing fasciitis, right? Necrotizing fasciitis usually goes affect the fascial planes. Okay, it doesn't really per se, cause severe, increased pressure within the compartment because it doesn't even get the compartment yet. It's pretty much on the fascial plane, right? But when you're talking about gas gangrene, pretty much, affects the muscles. Gas gangrene is also called myonecrosis. Okay, myonecrosis. So when you have myonecrosis, guess what happens to the muscle? Do you guys know? Myonecrosis.
It breaks down or like dies.
It dies and it forms rhabdomyolysis, right?
Oh.
Now, what is the number one differentiating clinical or OR test to see if you have necrotizing fasciitis or gas gangrene? What do you see clinically on the OR?
Crepitus?
Both of them can give you crepitus. Okay, keep going. What's the main one that really kind of differentiate between those 2 conditions? I'll tell you because it's sake of time. Necrotizing fasciitis or true necrotizing fasciitis that hasn't advanced into gas gangrene, the muscles are not affected. True or false?
Can you repeat that?
A patient with necrotizing fasciitis, okay, when you debride those necrotizing infection, the muscle is pretty much clean. It's not really affected.
True.
That's right. It's true. It's true.
Mhm.
Necrotizing fasciitis pretty much affect the fascial planes, okay, and doesn't really affect the muscle. Now, when an advanced stage of necrotizing fasciitis, then you could get infection into the deep muscles. But again, the fascial plane is maintained. So when there's something called a finger test, and we'll talk about that called a finger sweep test. With a finger sweep test, when you put your finger into the fascial planes, when you could easily debride the fascial plane, that means that the infection is traveling up, and until your finger can't go past a fascial plane, that's when you should stop debriding. Okay. So when you don't debride the fascial planes, you'll notice that the muscle is not really affected with necrotizing fasciitis. But with gas gangrene, the muscle is necrotic, the muscle is dead. Most of the time, you see abscess within a compartment. Okay. Actually, the original fasciotomy actually was performed on a patient with necrotizing infection. You have to remember, necrotizing infection it could be necrotizing fasciitis or it could be gas gangrene or myonecrosis. So it was really performed on a patient that's got a severe gas gangrene with abscess within a compartment. And that abscess within a compartment, caused increased compartment pressure, leading to rhabdomyolysis, leading to compartment syndrome. So you can get a compartment syndrome with gas gangrene. Can you also get a compartment syndrome with a patient with necrotizing fasciitis? 100%, especially with a patient that's got an advanced stage of necrotizing fasciitis where it went from just the fascial plane that's going deep into the muscle. Then you can also get compartment syndrome. So anyway, what I'm trying to say is that things that could lead to increased compartment pressure includes your trauma, your Achilles ischemia, your infectious process, especially the gas gangrene. Necrotizing fascia can also cause it too, but mainly your gas gangrene with abscess within the compartment, and also the DVT types. Remember your Cerulea alba, Cerulea. You have the phlegmasia, Cerulea, phlegmasia alba dolens, phlegmasia Cerulea dolens, and also venous gangrene. Among those three, I'd say among these two, phlegmasia alba and phlegmasia Cerulea, which one of those could lead to compartment syndrome? Right. As you know that.
He read the book.
Good. Good. It's in the book. Thank you. And also we talked about it. So anyway, what I'm trying to say is that, the phlegmasia alba, okay, doesn't really necessarily lead to compartment syndrome. But the main one that do lead to compartment syndrome is your phlegmasia Cerulea, who also leads to compartment syndrome. And actually, in those people, they will give them anticoagulant, and not only just that, they'll remove the clot within the vessel, and not only just they do fasciotomy. So these are your things that could lead to compartment syndrome or increased production of rhabdomyolysis. Any questions about that? Are we good? Yes?
Yes.
Okay. Why is it important that you should refer this patient to a vascular surgeon as soon as possible? Patient with Achilles ischemia.
You have death of the organ or death of the muscle after 8 hours, 6 hours.
6 to 8 hours. That's right. So you
Yeah.
gotta get them to the vascular surgeon as soon as possible. But before you get them there, you have to medically manage them. So be careful when we ask what are the medical management for ALI. You should know what that is. What are the surgical management? You should know what that is. And also, when it comes to the labs, you should order for a patient that you're suspecting to be having compartment syndrome, Achilles ischemia, or rhabdomyolysis. What are the blood tests you could order for these people?
CPK, myoglobin, and CMP.
Which CPK?
MM.
Absolutely. Exactly. So just make sure you remember that. Can you also order urinalysis on these people?
Yes.
Okay. And what kind of color will you see?
Coca-Cola.
That's right. Okay. Does that make sense? And when you see the Coca-Cola color or the color, they call it the tea colored urine, are you suspecting possibility Achilles ischemia? Yes. Are you suspecting possible compartment syndrome? Yes. Are you suspecting possibility of a compartment syndrome caused by infectious disease? Yes. Okay. So just make sure you know that when you see that urine color like that, that means that you have rhabdomyolysis, and you should be suspecting anything that could lead to compartment syndrome. We're good? Okay. You should know the differences between intermediate claudication, pseudocaudation, and venous claudication. Are we good with that?
Yes.
Okay, let me give you an example. A patient present with cramps in the leg that gets better after 30 minutes. Which one is that?
Intermittent claudication.
After 30 minutes.
Venus.
Venus.
Be careful. Listen, be careful. After 30 minutes is venous. A patient with claudication that gets better with compression.
Venus.
Good. A patient with cramps after walking a couple of blocks, that gets better within 5 to 10 minutes.
Arterial.
A patient that has to change position to improve numbness and tingling and cramps in the leg.
Pseudo.
A patient with spinal stenosis that has to change position to improve the pain.
Pseudo.
Good. Excellent. Now, this is the one that's going to get you guys. So I want to focus a little bit on this one. I should be done with vascular in about, it shouldn't be long. This won't be long at all. I think you guys are pretty ready for this. So when it comes to intermittent claudication, what's really causing the pain is an occlusion somewhere. Okay. And it's very important that you could find the site of occlusion. Okay. And whatever the site of occlusion is, the pain is distal to that. Okay. So let me give you an example. If a patient has a thigh cramps or thigh pain, I didn't tell you exactly where the where the location of that pain is. I didn't say, lower 2/3 of the thigh. I didn't say upper 2/3 of the thigh. I didn't tell you nothing. I just said a thigh pain. So what do you assume should be the area of occlusion? Should we include SFA with it?
No. No.
Absolutely not. So that means anything proximal to the thigh is the site of occlusion, okay, which could be the common femoral, could be the iliac, could be the aortoiliac, okay? So please make sure you are aware of that. But if I tell you exact location, where this pain is, then you could kind of guess off of that, okay? So let's give a couple of examples. A patient that is having thigh and buttocks pain, where do you think might be the site of occlusion?
Iliac.
Good job. You've been studying. A patient that's having bilateral calf pain, what could be the site of occlusion?
Aortoiliac.
Good. A patient that's having pain in the upper 2/3 of the calf.
SFA.
Good. A patient that's having pain in the lower 1/3.
Popliteal.
Popliteal.
Fix that. Are we good now? I think that was the issue on the exam. I just want to make sure you guys are good. Okay. Yeah. Okay. So if I say calf pain, patient's having calf pain, okay, where could be the immediate site of occlusion?
SFA or popliteal.
It's SFA. SFA.
Who just broke my heart? Who broke my heart? Who said calf pain? And who said popliteal?
Well, no, because you said that it could be if it's
Who's
in the
talking first?
calf.
Who's talking? Let me see who's talking.
It's Debbie.
Debbie Molebi. Oh, you broke my heart.
No, I know that you said if you don't clarify where in the calf, then it should be assumed it's SFA, but theoretically it could also be popliteal if it's the lower calf.
Let me ask you the question again, Debbie.
Okay.
You have to
Sure.
remember we are learning together. Okay.
Yes.
I want to make sure you get 100 on the exam. Okay. My job is not to make sure you fail. So I want to make sure I correct all mistakes right now. I'm going to correct all mistakes. Okay. I'm not
Okay.
taking the exam. I'm sure you correct that. If a
Okay.
patient is having calf pain, Debbie,
Yes.
where could be the site of occlusion?
The SFA.
Why can't you just say papilio?
Because that's only lower calf.
That's right. So when you say calf pain, you got to ask me, where exactly is your pain? Lower 1/3, upper 2/3, right? You got to ask the patient,
Yes.
right? If the
Yes.
patient, it's just my entire calf. I don't know, just my entire calf.
Well,
The
entire calf, yeah, entire calf is SFA.
Right. So that's what I'm saying. If I give you an anatomical region and I'm not telling you exact location, you should assume it affects the entire thing.
Okay.
Until I tell you so.
Okay.
Make sense?
Yes.
All right, good. Excellent. You guys got this already. Let's get okay. You should know this concept. What differential diagnosis for intermittent condication, right? Baker cyst, chronic, compartment syndrome, statin myopathy. What is the statin myopathy, by the way? What is that?
Muscle pain from taking statins.
Okay, and how do you treat it?
It's the same thing with the drug.
That's right. Anybody has any problem with that? Yes, we're good?
Good.
Okay. By the way, if you answer faster, we could finish earlier. So, but again, if you don't understand, please do me a favor. I'm not here for people that are, really good already. They're really excellent. I'm talking about, everybody. If you're just struggling in the session, just ask me the question and we'll be able to dissect it for you. We'll go over it together. Okay, Berger's test. So Berger's disease. Can Berger's disease lead to intermittent claudication or cause intermittent claudication?
Yes.
Yes, absolutely. Yes. Okay, and how do you treat their pain? Why do you treat it? What do you tell them?
Stop smoking.
Smoking.
Not smoking. That's it. Okay. Popliteal artery cystic adventitious disease, PACAD. Okay. You should know this very well. Can that also cause intermittent claudication?
Yes.
Is this common in elderly people or younger people?
Like mid-30s.
Younger population. This condition common in elderly or younger population? Younger. So basically, I didn't stress that when we're doing review. I just want to stress that again, that when you have this condition, PACAD, and your popliteal artery entrapment syndrome, those are really seen in younger people because they don't have any PAD. They don't really have poor circulation. It's just some kind of anatomical variant that's really happening with them that's causing this problem. So with the popliteal cystic adventitious disease, again, you guys know that already. What's really happened is that you have this a cyst that's been formed in the adventitia, which is also called tunica externa. Okay, and basically, what's really happened? That's compressing the intima, and that will narrow the intima. So, listen to this; it's very important. Clinically, when you flex the knee flexion will cause disappearance of pedal pulse. Okay, so you have a patient that has no history of PAD, young person, you can feel their pulses very well. Then you tell them to flex the knee, and now the pulse is completely gone. No more DP, no more PT. Okay, what do you call that sign?
Ishikawa sign.
Okay, Ishikawa sign. Is Ishikawa sign same thing as Shimitat sign? Are they same thing?
No.
No.
Why not?
Schmidt-Tar is like the hourglass on the angiogram.
That's the difference. The Shimitar sign is seen on an angiogram, not clinically. Big difference. Ishikawa is seen clinically, whereby Shimitar sign is seen on the angiogram. So when you do an angiogram, you see a patient with this, you flex their knee, and you notice that you see the stenosis, hourglass stenosis. That's called Shimitar sign. So that's very important. You need to know that. Okay. All right. What's also very important here is that this also could lead to intermittent claudication in young people, but it's not same thing as your PACAD. With this right here, when you dorsiflex or plantarflex, you could get an occlusion of the vessel or diminished vessel, whereby with PACAD is the knee you're flexing. With this, is pretty much just moving the toes, the ankle up and down. So you have to know the difference between that. Okay. All right. And you guys noticed already, the papillary artery injury that could lead to ALI. Okay. So you got, I'm not going to waste time on, oh, yes. So when you have renal phenomena, can you talk to them about the color? What do you see first?
White and then
White, then
blue, blue and then red.
Red.
Beautiful. What's your diagnosis?
Mockingbird calcification.
What type of atherosclerosis is this? What type?
Calcified type.
Calcification.
Or the Mockingbird, okay? Which vessel are really affected with this?
Medium and small.
Okay, so this is what I'm saying. Like, you have to just know that. You know what I mean? Just know that. If I say atherosclerosis affects the medium and the large, right? When I say atherosclerosis, it affects the small and the arterial. So you have to know that, and know, is it affecting medium? Is it affecting intima? Is it affecting the external? Kind of like that. So you have to just know that very well. And this could be seen in what population? Elderly, right? Rail tracking, right? It looked like railroad tracking, same thing as your calcification of vessel. So you can see this in elderly, diabetics, chronic renal disease, and all this other stuff. Any question? Okay. We discussed this already, so I won't go in depth about that. Did you guys go over this already in my recorded lecture?
I think this was the first case you had us do in class.
But also it was in my recorded lecture. Did you guys go over that?
Yeah, it was in your recorded lecture.
Right. So you know the answers already. So just make sure you go over it one more time. Okay. Does anybody want to go over this again? No? Okay. All right, you guys got this. A patient with ABI of 0.51. What's the next best test for a patient like this?
Exercise ABI.
Oh my God, just broke my heart. What's that? It's okay. It's
Sorry.
fine. It's
Sorry,
okay.
Cheyenne.
Who's this?
Cheyenne.
That's fine. Don't worry about it. I love what you just did. Thank you. Because that's why I'm here. To make sure I correct all mistakes. I want to correct all mistakes so that on your board exam, you get hundreds. Okay. Cheyenne, why do you think this is wrong? I said a patient with ABI 0.5, what's the next best non-invasive vascular study? You said exercise ABI. Why do you think you're wrong?
I'm assuming the ABI is too low for exercise ABI to be done.
What's considered okay, acceptable for you to order exercise ABI?
To be honest, I'm not sure. I think maybe 0.7.
Normal ABI.
It's a normal
0.9.
API. So 0.9 to 1.2.
Right. So it's 0.9. Now on a board exam, use that 0.91 or 0.9. That's what is acceptable. Some people say 0.8 is okay, and they'll go ahead and do SSABI. But do me a favor for the board exam and for the exam on Tuesday. I give an example. Can a patient have gouty attack with a very low uric acid level?
Yeah.
Yes.
Right? But guess what? On the board exam, they're not going to do that to you. They're going to tell you this patient has an elevated, uric acid level. Okay? Even though clinically, right, that you could have a normal uric acid level, and you see you have gout, but on the board exam, they're not going to do that to you because they want to make sure they kind of steer you towards gout, because a gout could look like osteomyelitis. A gout presentation could look like, septic arthritis. You got to push you a little bit to the right answer. Okay. Oh, another example: a patient that's got a wound in the bottom of the foot is diabetic. The best treatment is offloading. And the number one offloading that's accepted in the board exam is what? TCC, right? Total contact cast. How many times have you seen a patient being placed on total contact cast in the clinic?
Never.
0. I don't do it, right? But on the board exam, that's what they're looking for. So what I'm trying to say is that for the board exam, do me a favor. When you see ABI of 0.9, like you say it's 0.9, use that. Okay, and they ask you what's the next best test, your answer should be what?
Spectral Doppler.
EBI maybe.
Could you do like PVR or a duplex?
How about this? Let me do this. I'll take out the best. Let me do this. A patient with ABI of 0.9, what is the next test that could be done?
Exercise.
Exactly. What I'm trying to say is anytime you see on normal ABI and patient is still complaining of pain, your next test really, I think, might even be your next best test. Your next best test might not be the gold standard, which is arterial duplex. I mean, if you see arterial duplex, if they say, what would be the best test for this patient, then you say arterial duplex study, with a normal ABI or whatever. But if a patient's having intermittent claudication, especially having pain, cramping pain, and the patient has a normal resting ABI 0.9, and they ask you, what is the next, right? The next.
Would it be segmental?
The answer is SSABI.
After exercise, wouldn't you do segmental?
After the exercise ABI, right? If they ask you again and say, what's the next best test? At that point, you're going straight to your gold standard, which is your arterial duplex study. Okay. So again, let's do it again, Cheyenne. Let's do it together. A patient with ABI of 0.5, since it's not, normal ABI, you want to stay away from what?
Exercise ABI.
Right. If it's a normal ABI, like 1, like 0.9 above and stuff like that, and they ask what's the next best, okay? Because patients having intermittent claudication in that situation, the best way to really find out their condition of perfusion is to really make sure they walk around. So you tell them to walk around, okay, or do exercise, okay, then you go back and do your ABI, and that will give you your physiologic ABI, which is a real ABI. And they, if it's more than 20% reduction, and that is pathognomonic for a PAD. Does that make sense?
Yeah, that makes sense. So
Right.
for this patient, then what would you do? Would it be like a TBI or toe pressure or something?
So for this patient at this point, I will go ahead and do anything apart from, my exercise ABI. I could do whatever I want, but preferably for me, I'll be doing arterial duplex study. Okay. So a couple of scenario: a patient with a ABI of 0.95, and they complain of intermittent claudication. What's the next test that you could order on this patient to really find out what's going on with them?
Exercise ABI.
Exercise ABI. What about the same patient? You do exercise ABI. It went from 1.00 or 0.9 something to 0.7. Do you think the patient has PAD?
Yes,
Why?
because it was a big jump from the regular ABI that we did.
What are you looking for? What's the cutoff?
The cutoff is 0.9.
No.
For normal?
Anybody else?
Isn't it a 20% difference?
Exactly. 20% difference. Do you
Okay.
understand that, Cheyenne?
Yes.
20% difference
Yes.
or 0.2. So more than 0.2 or more than 20% difference is considered that the patient has PAD. So
Correct.
if you have a patient who's got a ABI of 1, okay, now it goes down to 0.7. How much drop is that?
The 30%.
That's 30% drop. That's it. That's PAD.
Right.
Does
Thank
anybody, by the way, listen, I love what Shannon just did right now. This is why I'm here. To kind of have a discussion, to go back and forth, to clarify some stuff. So on the exam, there's no mess up. You're not making a mistake. You understand the material. My exams is to test that you understand the material. I don't want you to just memorize and just drop it. It's not going to happen. You're going to fail. If you don't understand it, you're going to 100% fail the exam. But if you understand the concept, you're going to get 100. Okay. Anybody else having a problem with that concept? Okay. Nobody. Okay. So let's go over Burger's test real quick. I'm going to give you a scenario. A patient that has got a venous insufficiency, when I put the foot down, when should the color come back?
Less than 5 seconds.
Malevi, what do you think? Is she right or correct? Is she correct or wrong?
I think she's correct.
Cheyenne, is she correct or wrong?
I think she's correct.
I don't like the word think. That means you're not sure. Again, the reason for the review is to make sure you are sure. Is she correct or is she wrong? Less than 5 seconds.
It's correct.
Correct. Less than 5 seconds is your venous. What about a patient when you put it down, you have that dependent rubor that takes about 20 seconds to come back. Is that venous or arterial?
Arterial.
What if you have a patient that when you elevate the leg is completely pale, you put it down, it's very, very red. Also called a sunburst effect. Arterial or venous?
Arterial.
Arterial. The reason why I say that is a little qualification here. For arterial, in seconds, it takes more than 20 seconds to come back, for the color to come back to being dependent rubor, even back to normal. Sometimes it doesn't go back to normal, it just pretty much just stay dependent rubor. And sometimes you have a patient that when you put their foot down, even less than 20 seconds, you notice that the foot is like so bright red. Okay. Now, not to confuse you, on the exam, the main thing you're looking for is the seconds, how long it takes, or dependent rubor. Okay. Now, another thing is you could have a patient that have vasodilatory problems, a condition, for example, a patient with gout. So if you have a patient, when you elevate their leg, the leg goes back to normal, right? And when you put it down, it goes back to being bright red. Okay. Patients like that could be having cellulitis also. It could be having active Charcot, active rheumatoid arthritis, right? So basically, you just got to be careful and read the stem very well. Just say, the patient presents with, I don't know, increased uric acid, okay? And they haven't severe pain to the first MPJ, even a small bed sheet, when it touches it, they have severe pain. That's kind of pushing you towards gout, So this kind of stuff you're going to be getting in an exam. Just pay attention to the stem very well and you should be fine. Okay, I'm going to do one more. A patient that you elevate the leg becomes normal. And when you put it down, it becomes bright red immediately. This patient is having severe pain, especially with a very hot weather. What could be your possible diagnosis for this patient?
Erythromelalgia.
That's right. That's right. So what you just did right there, who did that? That's Malevi, or who's that?
Yeah, that's me.
Okay, so that's what I'm looking for on the exam. That's kind of what you're going to be getting. I'll give you a scenario, or if I tell you this patient, after surgery, their foot is very hypersensitive, they have a severe pain, so I'm pushing towards Crips. Okay. Anyway, so that's just that. Don't forget, venous is less than 5 seconds. Arterial is more than 20 seconds. Okay. All right. You guys know that already? Okay. When it comes to your inhale Doppler, What angle should you place the probe? Anyone?
45?
Can I do 90?
No.
No.
Can I do 75?
No.
No.
Good. So it's 45 to 60, right? 45 to 60. Very important. Okay. Edema, you guys know this already, right? If it's 0 divided by 2, 2 divided by 2, give it plus 1, 4 divided by 2, give it plus 2, 6 divided by 2, right? You guys get that?
Yes.
So you'll do that for the exam, but clinically, you got to use the time. Okay, you got to use the time. Okay. If it disappear immediately, that's no pitting. If it takes a little, it disappear and just a little long to disappear, less than 10 seconds, that's plus 1. More than 15 seconds, plus 2. More than 1 minute is plus 3. So on the clinic, you have to use a stopwatch and do that clinically. But on the exam, that's the easy way to do it. Okay, stemma sign. True or false? A patient with lipedema, okay, lipedema, not lymphedema, lipedema, true or false, they will have positive stemma sign.
True.
False.
Who said true?
Oh, I said true.
Why?
It was lymphedema, right? Or lipedema? Which one was it?
Lipedema,
Oh, lipedema is false. Lipedema is false. Lymphedema is
Thank you.
true.
True or false? Lipedema affects the foot.
False. Lipedema doesn't.
Thank you. Okay, good job. Good job. Excellent. Excellent. Okay, so I'm going to Dr. What's the nurse's name? Dr. Burston's lectures now. True or false? A calcium channel blocker could lead to edema.
True.
True.
Okay. Motrin, Lyrica, steroid, hormones could lead to edema.
True.
True. A patient with Graves' disease could have bilateral edema in the leg.
True.
What do you call that?
Pretibial myxedema.
Pretibial myxedema. Good job. What if I tell you a patient got bitten by a mosquito and now they have severely elevated, severely swollen leg that's not compressible? And what do you call that?
Elephantiasis.
Elephantiasis. So this is the kind of question you're going to be getting, guys. It's not going to be straightforward. Not going to be straightforward. I don't want you to just memorize and regurgitate and just push it down. Nope. Tell me that you understand. That's why I'm doing a review, that you understand it. A patient that's got bilateral crackles, rows, increased JVP, they have hepatomegaly, what could be the cause of the swelling in the leg? Crackles, increased JVP.
Right heart failure.
Which one? Right-sided or left-sided?
Right.
Yes. Who's that? Who's that?
Lori.
Oh, Laurie, good job. You're ready for IMED. Beautiful. Anyway, that's what I'm trying to say. This medication, Lyrica, what is that used for?
Is it nerve pain?
Right, nerve pain, exactly. So if we give a questions like a patient present with bilateral leg edema, never had a history of it. This edema started after being placed on the medication. And we say, what could be the possible cause? Oh, how about this? Patient with history of diabetes, hypertension, I don't know, some other disease, whatever, just guessing, cholesterol, whatever. Patient was just placed on a medication, never had a history of swelling. Unfortunately, a week later, after being placed on this medication, just started having bilateral edema. What's the cause of this edema?
Amlodipine.
I didn't tell you the drug. But what's the cause of that edema? you're going to say drug induced, right? Yes.
Yes.
Now,
Yeah.
if I tell you now, this patient was just placed on Motrin for, I don't know, knee pain, and it's after having some swelling, then the answer is going to be Motrin. If I say amlodipine, they're going to see the answer means amlodipine. Does that make sense?
Yep.
Okay, good. All right, we went over this. So lipedema, stimulus sinus negative, doesn't affect the foot. No foot involvement, okay? What's your diagnosis here? Bilateral edema, shiny. Is the only edema that shines like this, very shiny.
Eczema.
That's right. That's right. Seen in Graves' disease is petechial mesothelioma. Okay. All right. Remember, you got Dr. Burns went over this. So let's keep going. Let's keep going. Borchardt triad. You guys know what that is, right? I'm a mnemonic. I use HIV, right? Okay. Yes. What is the omen sign?
Pain on dorsiflexion of the calf.
Katiana, do you think is correct or wrong?
Wait, what did he say?
I said pain on dorsiflexion of the calf, ankle, whatever.
Pain in the calf area after dorsiflexion is your definition of omen sign.
That's not my definition, no.
What's your definition of omen sign?
Elevating the leg to 10 degrees while compressing the calf while the patient is supine.
Debbie Malabi, what do you think?
I agree with Kat's definition, the elevating the leg 10 degrees and then pain and tenderness on in a supine position.
What are you doing with the ankle? Are you just pressing the ankle or are you compressing the calf?
You're compressing it?
It's on dorsiflexion of the ankle.
Are you changing your mind now?
Yes.
Are we good now?
Yeah.
For some reason, I don't know why people always get this wrong. I don't know why.
So are you're dorsiflecting the ankle, but you're not elevating the leg?
Elevating or not elevating, that's not really the main thing. What's the main thing is really that dorsiflexion when it comes to omen. Patient is supine on both. Okay, and basically the most important thing you're doing is you're not compressing the calf when you're doing omen. You're only dorsiflexing, okay, the ankle. When you dorsiflex the ankle, that puts pressure on the in the calf area, and that will cause pain. That's omen. With Pratt, basically you are elevating the leg and compressing the calf muscle, okay? And if you have pain there, that's Pratt. So the way I remember this, just like your computer, PC, Pratt's compression of the calf, whereby your omen is the opposite, dorsiflexion of the ankle that will cause pain in the calf area. So you need to know that. So you're right. Are you elevating the leg? Yes. Okay. With omen, you are dorsiflexing. With the Pratt, you are compressing the calf muscle. Any questions? Did I lose you?
No.
No.
I thought Dr. Bernstein went over this. No? Is it Bernstein or who went over this? I think it was Bernstein now. Yeah, Bernstein went over this. Are we good now?
Yes.
So PC compression of the calf. Pratt's compression of the calf, right? Whereby omen is dorsiflexion. You have to know that, okay? Okay, don't forget this. DVT, I am clotted or thrombosis. All right, I say it all the time. They love thrombosis on the board exam. They love it, and I love it too. The reason why, because it's more challenging, okay? By the way, I am clotted and thrombosis, pretty much I just, when you're talking about the virtuous triad, a virtuous triad is pretty much a summation, of I am clotted and thrombosis, okay? But if you want to go into depth about your virtuous triad, that's where you're going to go into this mnemonic. But I like this a lot for the fact that when it comes to H, your hypercoagulability, which is your factor 5 lighting. Remember, we talked about that on Friday. Factor 5 lighting, when that's positive, your sensitivity is very high. Factor C, protein C and S. You need protein C and S for the activation and proper functioning of your heparin. Okay, so the way you think about that is protein C and S deficiency will give you DVT. Antithrombin 3 deficiency, okay, antithrombin 3, not antithrombin 2, not antithrombin 1, antithrombin 3 deficiency will also cause you DVT. So you have to know your thrombosis very well. Katiana, what is Prass test?
Squeezing,
Good.
compressing,
What's Omen?
dorsiflexion,
Good. What is the a best screening test to rule out DVT?
D-dimer,
D-dimer. Good. And to confirm, ultrasound. So the reason why I would say screening is because there's this Wells criteria that talked about DVT, and they say, listen, if you're suspecting DVT, you're suspecting it and it's a low suspicion, you want to do D-dimer. If it's negative, you don't have DVT. So basically, if it's positive, then you want to do your ultrasound. But if you have a very high suspicion, very, very high suspicion, you want to go straight into your ultrasound and just make sure, you have a blood clot. And your anticoagulant, so I won't go into depth about that. Let's keep going. Oh, yeah. This is very important. Alba means white. Cerulean means blue. This will give you compartment syndrome. This will give rhabdomyolysis. This will give you your urine, your tea-colored urine, or your Coca-Cola color urine. Okay, this also will do the same thing. So these two will give you a compartment syndrome. Unfortunately, when the compartment syndrome is not really addressed, that's when you're going to get your venous gangrene. And with the venous gangrene, at that point, you're doing amputation. Varicose vein. Okay. What I want to go over real quick about this one is when you have your microvascular circulations, your microvascular circulation includes your toe pressure, right? Your TBI, your TCOM, your SPP, that's what's called the skin perfusion pressure, which they use laser Doppler for. Another one that I didn't really bring up that much in my review is what you see on your iPhone, what you see on your wristwatch, your smartwatches. Is called the PPG, okay, photophotomography. So PPG pretty much also is very similar to a PVR, okay, but the difference is this measures your microcirculation, okay. So microcirculation includes your PPG, skin perfusion, your TCOM, your toe pressure, and TBI, okay. The best, okay. Cheyenne, you still here?
Yeah, I'm still here.
Okay, Cheyenne, let's do this, right? So you have a patient, let me see. The function of the exercise ABS to tell you if you're acceptable ABI, whatever. So if you have a patient that's got a ABI of 0.9 to 1.0, let's just say 0.91 to 1.0, that is acceptable. That's, that's okay. All right. If you see that, right, Cheyenne, should you order exercise ABI on a patient that's complaining of calf pain?
Yes.
Okay, good. What about a patient that's got an ABI of 0.5? Should I order exercise ABI on this patient?
No,
Why not?
because they have moderate arterial disease and
Right. So the reason why you want to do exercise ABI is going to tell you your physiologic or your true ABI, meaning that what's a true ABI when a patient is walking around, okay? So that's good. Excellent. So you got that. Oh, by the way, you should know how to calculate your ABI. You guys got that down? You guys know how to do it? Yes? Don't forget, you see that which one is higher between these two, DP or PT? Which one is higher between these two? Okay, so it's very, very important. And also, when it comes to the brachial, it doesn't matter left or right. Is which one is higher between two, and whichever one is higher, that's the one you're going to use for both the right limb and the left limb. Okay. Any questions about that? Are we good?
Yeah.
Okay. So, what would give it away that our patient is having elevated ABI? I'll give you a scenario. Number one, a patient that have calcified vessels. True or false?
True.
True. A patient that has diabetes with neuropathy could have an elevated ABI. True or false?
True.
True. True. Exactly. True. Good. This one's very tricky. A patient with biphasic 2 could have elevated ABI.
Sure.
Was that true?
I said sure, but
What's the name?
I don't have a reason.
What's the name?
John.
John, you're 100% correct, John. 100% correct. I'm just trying to find what I'm looking for. It's not here. Geez, sorry. Let me see if I can find it. Oh, it's right here. Good. Guys, let's read this very well right here. The forward diastolic flow. The forward diastolic flow. What's really happening? The vessel is recoiling. That means the compliance of the vessel, right, is very high. The vessel is recoiling. Can a vessel recoil when you have calcification?
No.
Yes.
No. It's hard. Okay, so when you have calcified vessels, you're not going to get vessel. The vessel's not. Okay, when you have a calcified vessel, is the compliance of the vessel high or low?
Low.
Low, exactly. So if it's low, can you have a vessel recoil? No. So what is really, again, I didn't bring that up during my review because I forgot. And when I was getting ready for your review session, I was like, oh, I need to bring it up. Very important. So basically, remember your biphasic 1 is when you don't have reverse diastolic flow. Biphasic 2 is when you don't have your forward diastolic flow. And here, if you don't have that forward diastolic flow, most of the time what's really happening is that your vessel's not recoiling, and that could be due to a lot of stuff. Okay. But one of the stuff that could be causing that is your calcified vessels. Okay. And right here, what's really affecting the reverse diastolic flow is when you have a very high peripheral resistance. A very high peripheral resistance will lead to a reverse diastolic flow. Okay. Another thing that I think is very important for you guys to know is what is really occurring here. Right here, you have upstroke, peak, systolic downslope, and right here, that's when your ventricle is relaxing, right? But when the peripheral resistance is very high, your rebound might be gone, okay? But when your vessel can recoil, okay, what's going to happen is that, you're going to have a, diminished or gone or not even existing forward diastolic flow. All right. Are we good? Any question about that? Are we good?
Yes.
Good. So when it comes to ABI, you should know your contraindication. Can I put a cough on a patient that's got a DVT?
No.
What about a patient that just had a wrist stem bypass?
No.
A patient that's got an incompressible vessel?
No.
Right? So you want to say from segmental pressure and the rest of them. Anyway. So this is your PPG right here. Okay. If you look at this PPG, doesn't that look like the waveform for PPG? Doesn't that look like PVR? They're pretty much the same thing, just a difference. So basically, your systolic upstroke, whatever, diastolic notch, same thing with PPG, so it's similar to PVR. What's your normal toe pressure?
0.7.
0.7.
Wrong.
70 to 100.
So basically, toe pressure is a pressure. It's not a ratio. 0.7, yes, that's for TBI. Okay. So this is 7 to 100 is normal, but when it comes to healing, you need 50 and above. Okay. So for wound healing, they say 50 and above is okay. So the number you're looking for is 50 and above. Right? It's the same number for TCOM. It's the same number for SPP. So your toe pressure, SPP, TCOM, the number they're looking for is anything above 50, you get some healing. Okay. When it comes to below 30, if your toe pressure is below 30, SPP is below 30, TCOM is below 30, what does that mean? Patient has severe critical limb ischemia, or PAD. Make sense? Are we good?
Yeah.
So when I say toe pressure, if you say 0.7, you're wrong. If you say 70, you're right. Okay, so be careful with that. A patient that's got a diabetic neuropathy, true or false, I should use segmental pressure to check for the vasculature.
False.
False. When you toe pressure TBI, don't forget your TBI has got to be above 0.7, above 0.7, not 0.7, above 0.7. Okay. Now, the reason why I'm focusing a little more on PAD because PAD is one that has the most lecture, the most hour, and on the exam, I think the exam is 55 questions. And basically, out of the 55 questions, I think PAD questions about 25 or 30. So it's a lot of questions on PAD. So just want to make sure that's what I'm going over real quick, aggressively again. Okay. Segmental pressure, you guys know this already. Don't forget, we discussed this during the Friday workshop, and I'm not going to go over it again. Are we good?
Yes.
Okay. You guys know this already also. Again, you should know this 1, 2, 3, 4. Okay. 5, which is your diastolic runoff. You should just know that and what's really happening. Okay. We went over it already. This is what I was talking about. Okay. This is your PVR right here. Okay. You don't see the diastolic notch. If you don't see the diastolic notch, that means it's mild. If it's low and wider, that is moderate. If it's almost flat, that is severe. Okay. So you guys, somebody has a problem with this one. This is your B mode or your gray mode, your color Doppler, because it's color. Your spectra is when that gives you your velocity, those waveforms, okay? You know that. Okay. Cheyenne.
Yes.
Biphasic or monophasic?
Monophasic.
Why?
Because there's only one peak.
Okay, let's do it. Okay, remember this is what you have to do first. You have to find out the start and the completion of that cycle. So let's do this, Cheyenne. Upstroke, yes.
Correct.
Downslope, yes.
Yes.
Reverse forward flow, right? And forward flow. Does that complete that cycle?
Yes.
Stops right there. Good.
Yes.
Let's do this one, okay? Ready? What is this? Upstroke, agree?
Yes.
Downslope, agree?
Yes.
Is the cycle completed already or no?
Yeah, I thought it was completed, but if you...
I'm asking, what do you think? Is it completed?
Yes, I think it's completed.
What's this one? What's this for? What's this?
To be honest, I'm not sure because I saw some where it had that and it was still considered monophasic, but I mean, to be honest, I'm not sure.
Okay. Let's see. Debbie Molebi, are you here?
Yeah.
That's why we are here, to make sure we clarify these mistakes, okay? Debbie.
Yes.
Up, down, right?
Mhm.
We don't have rebound for flow. We don't have rebound flow, right? Is the cycle completed or is it still going?
I mean, I'm honestly for this one, I'm between monophasic and biphasic 1 because I'm unsure if that's a second peak or not.
So Debbie, you are on the
Yes.
right track. So stay on the right track.
So that's either another peak or it's a rebound.
Debbie, you said
No,
something.
it's not a
very
rebound. I'm
important.
sorry. I'm sorry. It's not. It's definitely not a rebound.
You said something that's very important.
Okay.
Let's don't change your mind. Stay right there. Let's do it again. Reverse diastatic flow,
Mhm.
all right, or your rebound flow, right, and forward diastatic flow, reverse diastatic flow, or your rebound diastatic flow. Does that make sense, guys? So make sure you understand that reverse
Yeah.
or rebound, forward flow. Okay. All right. Let's go back. Okay. So Deb, let's start with this one. This before you go to the next systolic peak, right? You have to complete the cycle. So
Okay.
this systolic peak right here, the next one is right here, right? Yes, agree.
Mm-hmm.
The next one's right here, right? Agree.
Yes. Yes.
Let's do this one. Systolic upstroke is right here, right?
Yes.
What's the next one? Right here.
Yes.
So
Oh, okay.
is this cycle completed right here?
Yes.
Is it completed right here at this point right here?
No.
No. Is it completed right here?
Yes.
Yes. So Debbie, you said something earlier. You said this is biphasic one. True or false?
True.
That's right. You're correct. This
Okay.
is biphasic one. Excellent. So let me repeat to the entire class. This is why we're doing this. Okay, let's think about it. You have to complete that cycle. And the only way to complete that cycle is when you start a new, okay, systolic upstroke. This is the first upstroke right here. That's the next one. That's the next one. That means the cycle is still ongoing right here. So that just means this patient does not have your rebound flow or your reverse flow, but they do have that forward diastolic flow. Cheyenne, does that make sense?
Yeah, that makes sense.
Okay,
So
because this is still continuous, right? And this is the beginning of a new one.
So if it was just a flat line, then it wouldn't be considered biphasic.
That's right.
Okay. Okay.
Again, we're going to make sure we give you one that is very easy to pick. You know, that's very easy one. Okay.
Okay.
So Cheyenne, let's do this one together. This right here, biphasic or monophasic? This one right here.
That one has two peaks, so biphasic.
Biphasic 1 or biphasic 2?
It's biphasic 2.
Beautiful. You got it. So this is what you're going to get on the exam. The one that is very straightforward. This is tricky. It's very, very tricky. This is very tricky. So I'm not going to give you that. You know, we're going to give you something like this, something like that. You know, like this one, Cheyenne, look at this. Monophasic or biphasic?
That's tricky. Honestly, monophasic. Monophasic. Yeah, because they don't look like peaks. It would be like so many peaks after.
That's right. That's right. Again, we're not going to give you that. That's really hard, but we'll make it easy for you. So let's keep going. Let's go to another one. Cheyenne, let's do this together. Okay, you ready?
Yes.
Monophasic or biphasic?
Monophasic.
Right. Again, this is again, if you've been reading this a long time, you figure it out. It's easy. You know, this right here is flat as compared to, it's kind of similar with this one. It's kind of similar.
Right.
You know, that's why it's a little tricky. You know, again, if you look up, there's no reverse flow, and right here something is happening. We have no idea, but it's a flat line. Okay, but we're gonna give you something that is very easy on the exam, so you don't get confused. Let me find another one. Another one here. That's easier. Sorry, give me 1 minute. Sorry, guys. Okay, so Cheyenne, look at this one right here. This one.
Mm-hmm.
Let's do this one together. Cheyenne, is this a bump or just a flat line?
Flat line.
Exactly. So that's your monophasic. How about this one?
That's also monophasic.
Right. Exactly. You know, so we'll make it easier. Oh, what about this one? Monophasic or biphasic?
That is biphasic.
Exactly. Exactly. Good job.
Yes.
Okay, so we got that. Any issue with that? Okay. We discussed this already, so we discussed that already. To save time, let's keep going. We discussed that. On the exam, we're going to give you this chart. Okay. All what you have to do is, if I give you a velocity, what you have to memorize is this right here: 80, 100, 80, 60. That's what you have to memorize. Femoral is 100, papilla is 80, and tibia is 60, right? So if I give you a pressure, a velocity of 300, at the femoral, and I say, what's the degree of stenosis? What will you say?
$50 to 80% occlusion.
Exactly. 50 to 80% of occlusion. That's how you read it. Any questions about that, anyone?
So you're going to give
So-
us this chart at the bottom?
Yes, you're going to get this. Yes.
Okay.
Because guess what? The radiologists also have this too. So it's just fair. So I'll give you this on the exam. Once you have to memorize, it's 100, 80, and 60. We're going to give a velocity. You divide it by whatever area I want you to divide at, whatever area we're talking about. And then whatever number you got, you go to degree of stenosis and be able to tell you. So if I say a patient has a, 120 velocity, at the DP, right? What's the degree of stenosis? Anyone?
Can you repeat the question?
A patient with velocity of 120 at the DP, what's the degree of stenosis?
Over 80?
20
20%?
to 50 or 50, 49 to 50.
So yeah, this one's a little tricky. You say something about 49 to about 50%. Okay, meaning that if it's 2 here, it's about 49%, and 2 is also starting here too, so it's about 49 to 50%, 50%. Right? Make sense?
Yes.
Okay.
In a situation like that, would you go based off, because I don't see the salus pedis on the chart, so I was just assuming it would be another 20 less than tibial, which would be like 40 instead of 60.
You could do 40, you could do 60. Again, that's the average. You do between 40 and 60. My recommendation is for you to use the higher 60, because tibial artery, that's your anterior tibial, and your anterior tibial goes into DP, so you want to use that 60. Okay. And if you use 40 also, is also correct.
Yeah, no, it's just okay. So as long as the chart says those numbers on the bottom chart, then follow those numbers regardless of what's the normal
Just follow
value.
those numbers. Just follow those numbers.
Regardless of what's the normal value.
Right. No. But let's say you want to do 40, like what you just said right now. Let's do 40. Okay. So let's do I said 120. 120 divided by 40. That's 3, right?
Yeah.
So now you could say this patient occlusion, you have to remember it could be 40 to 60. So you could say this patient occlusion could be between 20 to 80%. I'm sorry, 49% to 80%.
Okay, yeah, that makes a lot of sense.
Get my point?
Yeah.
Right. Katiana, we good?
Yes.
Okay. All right. Hey, you guys, we did this already, so I'm not gonna go into depth about that. There's something I want to cover. I want to make sure I cover everything. We covered this already. We'll cover that. Oh, yes. We discussed this already. Yes. Remember, I told you should know this. Yeah, we're good. Right? So if a patient has a wound, on the dustum of the foot, you worry about your salus pedis, right? Your anterior tibial artery that will supply that area. Again, just know your branches, know your feeders. The feeders are the main branches. Your branches, if it's like more lateral, it's going to be fed by, the anterior peripheral of the PA. So that means the salus pedis and the PA. If it's a lateral calcaneus, okay, then what about the lateral calcaneal artery? If it's a plantar lateral, okay, lateral plantar artery, okay. If medial plantar, it's being supplied by your PTA, okay, but specifically it's going to be the medial plantar artery. So anyway, just know that. Like number 6, right? Number 6, what is supplying that area is your subplantar artery. Okay. Does that make sense?
Yes.
Okay. Another thing that you need to know about this is, pretty much your infrared tomography. So if you compare both, if you look right here, where's the disease? You can tell the disease is located right here on the big toe, right? Because you're comparing it to the contralateral. That's it. That's what you have to know. Nothing else. Okay. Don't forget your vascular tree. I'll give an example. If a patient has an occlusion to D, all right, would they have a good flap dorsally or plantarly? Patient has an occlusion of D.
Dorsally.
That's right. Cheyenne, does that make sense?
Yes.
Okay, because D is posterior tibial. Your posterior tibial means that there's no flow going to the bottom of the foot. So that means you have to flap down. Does that make sense?
Yeah.
Okay. Now, this is very important. The first treatment for a patient with PAD is your lifestyle modification. If you do lifestyle modification and they're not getting better, what's the next thing you have to do?
Medications.
Medications. Now, there's 2 medication that you could use for PAD. You could use both. You could use pentazephyline or you could use tilostazol, both. But which is the only one that is currently approved by the FDA?
Tilostazol.
Right. So can you use pentazephyline? Yes. Is it approved by the FDA right now? No. Was it approved before by FDA? Yes. But currently right now, no. Okay. But you could still use it for PAD. But so that's why you gotta be careful on the exam. If we ask you which one is the current guideline, the current guideline is tilostazol. Okay. The current guideline is tilostazol. Okay. So let's say you put a patient on tilostazol and it's still not getting better. The next thing is to do revascularization. So that's very important. You should know that. Okay. Another thing I want to bring up that I didn't think I brought up very well, I didn't talk about it very well, is this thing right, heart assist. Does anybody know what an heart assist is? Heart assist, arterial assist?
No.
Anyone? Did you watch my video?
Is it the machine thing?
Thank you so much. It's a machine. Basically, it's a intermittent compressive machine. It's a pneumatic device. It's almost like the same thing that you see, when you have to do surgery and they wrap it, so they wrap on your leg, so kind of intermittently compress your leg. So it's similar, same thing, same idea, but it's got a different pressure. And the function of that device, okay, is to improve your ABI. And studies have shown that a patient that is not a candidate for bypass or not a candidate, for angioplasty because they're very sick, you could use at least the heart assist to improve their ABI by 0.12 to 0.15. Again, I discussed that in my lecture. I hope you guys watched my lecture. Okay. And that's it. Oh, one more thing. What is the number one problem with endovascular procedures?
Restenosis.
What is the gold standard for revascularization?
Bypass.
And when should you do a major surgery after bypass?
4 to 10 days. After
What
4
about
to
angioplasty?
10 to 30.
Right. So basically, on your board exam, the answer usually is going to be, 10 days. But if they ask you specifically bypass for the 10 days, angioplasty 10 to 30 days. But just say after revascularization, you should just go with the gold standard. Okay, these are the kind of the tricky thing on the exam. If they're not telling you bypass or angioplasty, and they're just telling you patient out of revascularization, you should assume the gold standard, which is the bypass, and your answer will be 4 to 10 days. Okay. DVA. With DVA, your artery must be higher than your vein. Your arterial inflow must be higher than your venous. True or false?
True.
True. Okay. Laurie, do you agree with that?
Yes.
Okay. And do you know why is that, Laurie?
Oh, so that the vein doesn't flow the other way?
I mean, you using a bubble tone to destroy the valve. The main reason why, because you want to have gravity push that artery into the vein. Okay, see this right here? The gravity is going to push that artery into the vein. So that's why it's got to be higher. The artery can be lower. If it's lower, then there'll be no pressure to push it down. Does that make sense?
Yes.
So the artery has to be higher than the vein, than the vein. So the inflow from the artery has to be higher. Okay. Again, they're showing you right here again. All right. So when should you perform a BKA?
If they're ambulatory,
What about AKA?
if they're non-ambulatory,
Okay. So that's it for PAD. PAD is a lot of questions. And what I'm gonna do when I'm done my review, I'm gonna ask you like question at random and see what you guys know, and we'll go from there. So let me go to the next one. That's very important. Again, you guys know this, right? This thing right here, we discussed that. So I'm not gonna go into depth about that. You guys got that, right? So I just finished the PAD, which is the most lecture, PAD. The next one I'm going to is neurology and also Charcot. Okay. These are all the signs of a patient demonstrating peripheral neuropathy: shooting pain, burning pain, stabbing pain, jabbing pain, right? Which one among this right here will tell you that the patient have small fiber neuropathy?
Shooting pain?
Say it again.
Shooting pain?
Shooting pain. Let me see what's here. Let me start calling names. I want to make sure everybody's on the same page. For some reason, my thing's not coming. Ajay, are you here?
Yep, I'm here.
Do you think it's correct? He's saying, a patient that's having shooting pain, most of the time, that's for a patient that's got a small fiber neuropathy. Is that true?
I thought that was like more autonomic things.
Autonomic disease, is that small fiber or large fiber?
I thought that was small fiber.
Oh, you just answered your own question. So let me go again. Shooting pain, small or large fibers?
Large.
Small fibers.
You just said autonomic is small fibers, right? I said shooting pain is small for autonomic, and yeah. So anyway, let me call somebody else just to make sure we're on the same page. I don't want to give the answer yet. Andy, are you here?
Which, like Miss Brenner or?
Yes, Brenner.
Yeah, I'm here.
Shooting pain, small fiber or large fiber?
Small fiber.
Good. So everybody listen to this. Remember that graph that I want you guys to know? You need to do that graph very well. They ask questions a lot on that. But the main way to differentiate between small fibers and large fiber, the small fiber will give you your painful neuropathy. Kind of weird. I can't have painful neuropathy. It's kind of weird. But anyway, your C fiber is affected. Basically, what you see with small fiber is that you're going to get that shooting pain. So anytime you see pain, okay, and a patient has neuropathy, think of a small fiber neuropathy. Okay. Somebody just share something. I don't know. Oh, yes. Thank you. We'll share that with you. Let me see your name. Excellent. Thank you for sharing that. I appreciate that. If you guys go to your chat, I think Mohammed is sharing something with us. This is a very, very important, slide here. This graft, they use it a lot. on exams. So if you look at small fiber, what do you see? Pain. When it comes to autonomic, you see, blood pressure that's elevated or, diminished, sweating and GI problems. But mainly, if you look at the large fiber, you don't see pain. You see muscle control, you see touch vibratory perceptions and stuff like that. But when it comes to small fiber, the main thing that differentiates between small fiber and large fiber is pain. Okay, thank you for sharing that. Are we good?
Yes.
Excellent. So true or false, a patient who's got neuropathy could also have similar symptoms as a patient with PAD.
True.
That's right. And the reason why that is because your nerves can't function without artery. So if you have microvascular disease, what's going to happen? There's something called vasovasorum. Okay, you guys learn that in anatomy. So when your vasovasorum is occluded, as you can see here, then there's no oxygen supply and perfusion to the nerve, and basically you're gonna have the same symptoms: cramps, burning, tingling, which is the same thing you see in your PAD. Okay, this is what I was talking about on Friday. Deng therapist. So a patient, okay, without neuropathy can never have Charcot. True or false?
True.
That's right. If you do not have neuropathy, you don't have Charcot. So if the patient has no neuropathy at all, and they have some kind of, fragmentation and orthopedic changes in your foot and your ankle or whatever, you better start thinking maybe they have a trauma in the past, or maybe they have osteoarthritis, or they have injury. Anyway, what I'm trying to say, for Charcot, you need neuropathy. Okay, all right. So that's your Deng therapies to make it easy for you. Okay. All right. So when it comes to testing for neuropathy, there's something called loss of protective sensation. Loss of protective sensation is pretty much testing for large fibers. So your monofilament, your Ipswich, your light touch, your pinprick, your sharp dull, your vibratory. They're pretty much testing for large fibers. Your reflexes, they're checking for large fibers. What can I use to check for small fiber neuropathy?
Biopsy.
Punch biopsy. Is Leah here? Leah?
Yes, I'm here.
Leah,
Mhm.
what other test can I use to test for small fiber neuropathy?
Pseudoscan.
Pseudoscan. And I don't think Dr. Brunson discussed it. So it's not going to be an exam, by the way, because we didn't discuss it. Maybe for next year, I'm going to make sure Dr. Brunson put in this lecture. So there's something called the invasive test for small fiber neuropathy. And there's something called non-invasive test for small fiber neuropathy, which is called pseudoscan. I'll discuss that in a minute. Okay, pinprick test. The pinprick test pretty much is just pretty much testing for, large fiber neuropathy, but specifically test for dermatomes. So you have to know your dermatomes. For L4 is your big toe, your L5 is digits 2 to 4, and your S1 is your pinky toe. Okay, so if a patient can't feel, okay, the pin at the base of the second toe, that's pretty much telling you that they might be having some kind of injury to their nerve root, L5. So that's how you use your pinprick test to see if patients having some kind of sciatica or spinal nerve root problems. Okay, any question about that? Nobody saying anything. I want to make sure we get this. Questions?
No, sir.
Okay. Again, straight leg test. You guys know that already. To rule out sciatica. Okay, you guys know that. So we're not going to go into depth about that. Let's keep going.
In this.
Okay. So let's ask question. Andrew Celia, you here?
Yes, sir.
Okay, you have a patient, okay, that's got a lower back pain with radiculopathy and numbness to the right foot. You do a pinprick test, okay, on the big toe and it was absent. What nerve roots is affected? L4 or L5?
L4.
Okay. Okay, that's the kind of question you guys are gonna be getting, things like that. Okay. We discussed that already. Okay. Reflexes. Again, I line this is very important. Your reflexes pretty much gives you your earliest sign of neuropathy. So it would tell you if you have motor or sensory deficit earlier than anything else, earlier than your vibratory, earlier than your monofilament, earlier than your Ipswich. Okay, it's very important you know that. Also, for the exam, you should notice the grading for reflexes. 2 is normal. Reflexes is not same thing as your muscle strength. True or false?
True.
True. What is normal in your muscle strength?
5 out of 5.
5 out of 5.
5 out of 5. 5 out of 5. 5 actually in reflexes is abnormal. It's for upper motor neuron disease. So it's very important. You should know the difference between those two. Your reflexes when it comes to grading 0 to 5, and also when it comes to your muscle strength. But the main thing I want you to get out of this is that when it comes to diagnosing an early neuropathy caused by motor and sensory, do reflexes, followed by your vibratory. Okay. 3 types of neuropathy: sensory, motor, and autonomic. Okay. We're going to give you examples on the exam and say, a patient with Amato, what do you think? That's motor neuropathy. Patient with severe dry skin, autonomic. Patient with loss of sensation of foot, that's sensory, right? Okay. Normal or abnormal? Let's play a game. Normal, abnormal. A patient with a monofilament of 6 out of 10.
Abnormal.
7 out of 10.
Normal.
Good. A patient with Ipswich of 1 out of 8.
Abnormal.
Abnormal.
2 out of 8.
Abnormal.
Abnormal.
3 out of 8.
Still abnormal.
Abnormal.
Say it again.
On 1 foot, it's abnormal if it's 2 and 1.
Shouldn't it be 4 out of 8?
What is considered normal?
Above 4?
So on the right side, 4 out of 4. Normal, abnormal.
Normal.
That's normal.
Okay. If I say 2 out of 4, normal, abnormal.
Abnormal.
1 out of 4, normal, abnormal.
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 What if I tell you I could feel sensation in 7 out of 8?
Normal.
I could feel sensation 6 out of 8.
Abnormal.
Normal.
Good
Normal.
job. Normal, abnormal. I love this. My job here in the review session is to wake you up to make sure you get the concept. Abnormal, abnormal. What is considered abnormal, by the way?
2 or
More
3.
than 2?
More than 2 or 2 and more.
I think it's 2 or greater.
Exactly. So if you lose 2 spots, it's abnormal. 2 or more is abnormal. This is why we do these review sessions. Are we good?
So then in that case, wouldn't 6 out of 8 be abnormal?
That's right. Abnormal.
Okay.
Yes.
So you need at least 7 out of 8 for it to be normal.
That's right.
Okay.
Does that make sense? Again, that's what we're doing this. That's what we're doing the review sessions, okay?
Sorry, can you quickly repeat that? I got lost in the end. I thought I knew it, and then I think I
Okay.
heard you say the same word twice.
That's fine. That's fine. That's fine. When you do Ipswich, it's out of 8, right? Agree, true or false?
On both feet combined, yeah.
I'm not sure if I have it here. Oh, I have it here. Good. Okay, I have it here. See this right? Say 2 or more. 2 or more.
So 2 or more missing neuropathy
Mm-hmm.
on both feet combined.
Yes.
Okay. Got it.
You're good?
Yep.
Okay. All right.
So just for me, 3 and 3 is abnormal. Correct?
That is when is it 3 and 2? What's that 3 and 2? What does that mean?
Like 3 on the left foot, 3 on the right foot. That's abnormal. 3 out of 4 left, 3 out of 4 right.
The best way to really you got to combine it. That'll be so you don't get confused. The best thing is to combine it.
Okay.
So if you combine it and it's 3 on each foot, that's 2. That's
Right.
abnormal.
Yes.
3 out of 4 on the foot.
Give me 1 minute. So what I'm saying is, for the exam and for the board, you want to combine both, right? You want to combine both. So 4 on one and 4 on the other. Total is 8, right? 2 or more out of 8, okay? When you combine them, it's considered neuropathy. Okay. Now, if you do it individually, it becomes a little tricky, right? For example, if I say on one side I get 3 out of 4, well, that's normal, because guess what? I could feel 3 sensations, 3 spots. I only miss 1, right? Let's go to the other side. On the other side, I get 4 out of 4, right? 4 out of 4. And what do you call that? That's normal also. Agree?
Yeah.
Yes?
Yes, sir.
All right, so let's do a scenario real quick. On the right side, I get 3 out of 4. On the left side, I get 4 out of 4. Is that neuropathy or no neuropathy? Let's go.
You said right side 4 to 4?
Left side is 4-4. Right side is 3 out of 4. They could feel 3 out of 4.
That's normal.
That's normal, right? Watch this. On the right, somebody asked that question. 3 out of 4 on the right, 3 out of 4 on the left. If you look at it individually, right? Abnormal or normal individually?
Normal.
Normal individually. When you combine it together, what do you get?
6 out of 8, which is abnormal.
That's right.
Which is why I'm confused.
That's right. So basically, what I'm saying is, for me, the best way to go about this is just combine them. Now, if you want to do it individually, then individually you could do that too. And you're gonna say on the right is normal, on the left is normal individually, right? Now, if you get 2 out of 4, I mean they can only feel 2 spots. Automatically, that's abnormal. On the left side, let's say on the left side, they get 3 out of 4. On that left side, that's normal. On the right side, it's abnormal. If you combine it together, it's abnormal. Okay, so that's what I'm saying. We're not gonna ask you individual question. We're gonna ask you combine. We're gonna combine it. That's the proper way of doing it. You gotta combine it together. That's the proper way of doing it. Combine it together. Does that make sense?
Yes, sir.
Okay. But if you want to do it individually for your own experience, okay, as long as they could feel, okay, if they could feel more than 2, that's acceptable, right? If they can't feel 2 spots out of 4, that's abnormal. That's neuropathy right there automatically. All right. Now, another way, if you want to do it that way, is if you want to know which one's got neuropathy, okay, you'll say, okay, the right one is 2 out of 4 and the left one is 2 out of 4. Well, 3 out of 4 is normal. Technically, if you go and do vibratory sensation, or if you do the pseudo scan, you'll find out that both of them has neuropathy. That's why they say when it comes to Ipswich, you should combine both. So on the exam, combine both. So when you have lots of sensation, more than 2 spots, more than 2 or more than 2 spots is neuropathy. Are we good?
Sounds good. Yeah.
Okay. Again, that's what we do review, right? We do review. So break it down to make sure you get it. So on the exam, there's no confusion. So always combine them, okay? Okay. I cannot say it. I cannot stress this enough. You need to know this, okay? I don't know how to tell you. We're going to ask you questions like a patient with a large fiber neuropathy, what kind of, fibers do you see? A alpha, A alpha and beta, right? Small fiber is all this, right? We could ask you, what are the symptoms you see in motor neuropathy? You're going to see muscle control. That's motor neuropathy. In sensory neuropathy, what do you see? You're going to see your vibratory, your touch, your perception, your cold, your pain, You're going to see all that for sensory. For autonomic, you see all this, right? If we go deep further and when I ask you and say, when it comes to small fiber, okay, what are the symptoms you see in small fiber? Even though in sensory, this way it gets confusing. In sensory neuropathy includes pain, cold, warm perception, and vibratory and stuff like that, right? But when it comes specifically to small fiber, the small fiber only involve pain. Okay, so you just got to be careful what question we're asking you. If it's sensory do include pain and everything else. If we say small fiber, main thing you're looking for, look for pain. Once you see that pain, that's a dead giveaway. That's small fiber, nothing else. Now, another thing that will give you small fiber is your heart rate, your blood pressure, your GI problem, incontinence, dry skin, sweaty feet. Does that make sense? What I'm trying to say?
Yes.
So I don't know how to teach you this. You just got to know it, and it's not just for me. On the board exam, they do the same thing to you. They'll do the same thing. They will say, our patient present with warm perception with severe pain. Okay. What type of neuropathy is this? They're going to say large or small. They're going to say small, right? They're going to say a patient has got a increased heart rate. What kind of neuropathy? Then it's autonomic neuropathy. A patient that's got a decreased vibratory sensation, right? What type of neuropathy is that? That's sensory, right? So things like that. Or they might ask you, which of the following fibers are not seen in autonomic neuropathy, right? Are not seen, right? Then we're going to say A alpha, right? A alpha and beta, all right? And A delta, okay? Guess what? A delta is seen in sensory. A delta is also seen in autonomic. So to not throw you off, we're going to say which one is not seen, right? It's not seen. So we're going to put alpha and beta. And your answer is your A alpha, A beta. And that's the only 2 that are not seen, in your autonomic neuropathy. Now, to even confuse you even more, we could now say all monolated, thinly monolated, and stuff like that. Anyway, what I'm trying to say, just be careful. You could see A delta in autonomic neuropathy. You could also see your A delta in sensory neuropathy. You could see C unmonolated in autonomic neuropathy. You can also see also in your sensory. So what really differentiates between sensory and autonomic neuropathy is your monolated A alpha and beta. That's what differentiates between this and this. And what differentiates between this and this, motor neuropathy and sensory neuropathy, is that the only one that's got the A alpha all to himself is motor neuropathy. The other one that has the A alpha and beta combined together is a sensory. So you just got to break this thing down and know it very well. I can't teach you this. You just got to know it. Any questions? Are you confused? Did I confuse you guys?
No.
No.
I think I clarified a little more for you, right? So I mean, to make it easier for you, I think I clarified. So just know that. Okay. All right. True or false? Can I see AO delta in both sensory and autonomic neuropathy?
Yes.
See what you just did right there, right there. There you go. Can I see A alpha in sensory and motor neuropathy?
Yes.
Yes, that's right. That's right. Can I see A alpha in autonomic neuropathy?
No.
No. Can I see small fiber neuropathy in lack of muscle control?
No, but technically don't just start with small, then progress to large.
Right, but again, it's large.
No, so no.
All right. Okay. So when it comes to neuropathy, okay, small fiber neuropathy precedes, your large fiber neuropathy. And for your large fiber, you're going to get that weakness, muscle wasting, impaired vibratory, loss of position sense, loss of reflexes. But guess what? When it comes to small fiber, guess what's the first thing you see? Pain, okay, and everything else. So when it comes to your large fibers, this is what a tissue could do, right? When it comes to your large fiber, this is what a tissue could do. When it comes to your small fiber, your ENFD or your sweat gland, NFD or your pseudo scan. Okay. I'll keep going. We got this already. We got this. Which one is more sensitive? The sweat gland nerve fiber density test or your epidermal nerve fiber density test?
Sweat gland?
The sweat gland is more sensitive. Pseudoscan. Okay, this is what it looked like. Pseudoscan is very easy. In my private practice that I used to work in, we used to have this, and it's very, very sensitive. Basically, what it is like, they'll tell you take off your shoe, take off your hand, take off your shoes, your socks, and you put your foot right here, and you put your hands right here. And what this thing is doing is just checking for your sweat gland function. Okay. Remember, we said before that your sweat gland is more sensitive than your ENFD, right? So this is pretty much checking for your sweat gland. Okay. So you would check how much sweat you're getting from your foot and from your hands. And it would check that. And pretty much will measure it. And then will tell you if the patient has a, small fiber neuropathy or not. So this is a non-invasive way, instead of doing the invasive, it's a non-invasive way of checking for a sweat gland function or the quality sweat gland functional disease or density. Any questions? Are we good?
Yes.
Okay. So you should know your definition: neuropraxia, acinotomesis, neurotmesis. Which one is the worst? Neurotmesis. Which one is the less? Neuropraxia. Okay. So anyway, know this very well. Did Dr. Brunson go over this with you guys? No? Yes? No?
I think
Can
he
you
said
go over it real quick?
A1C was times 20, right? That's whatever you got for your A1C times 20 is your blood glucose.
Let me just do it real quick. So the first thing you have to do is to remember the A1C of 6 is approximately 120 mgdl. Okay, so it'll give you a blood sugar of 120, A1C of 6. Okay, that's the beginning. For every 1 increase in A1C, you're going to add 30. Okay, so if you have A1C of 7, okay, that's 6 plus 1, that's 7. So you're going to add 30, so that's going to be 150. A1C of 8, okay, you're going to have 60, that's going to be 180. Does that make sense?
Yeah, so just to clarify, Dr. Bernstein did say that it was the A1C times 20. So should we go by this for the exam or by that scale? Because it would be different.
So you say A1C, so it's like
so like for example, an A1C of 6 would still be 120, but an A1C of 7 would be 140, and an A1C of 8 would be 160. So should we go by that scale, or is this the correct scale that we should use for the exam?
Great question. um, um, hmm. Okay. Um, well, nope. Well, Dr. Brunson is right. Dr. Brunson is right, and everybody's right. So you can. Both of them are right. Okay. I just yeah. So you say 6 times 20, 7 times 20 will be this will be 160. I mean, it's an estimate, it's an estimated average. On your board exam, right? You should use this formula on your board exams. Use this formula. I think both of them are correct. Don't get me wrong, both of them are correct, but use this formula. Okay. Yeah, use this formula. And
Okay, thank you.
on the exam, I I'm not gonna test you on this. I'm not gonna. I don't want to confuse you. I'm not gonna test you on this. How about that? So, but for the exam in the future, on your board exam, you should use this. And both of them are correct. It's the estimated average blood sugar. Widely accepted is this right here. This calculation. That's what's widely accepted. The one that the Boston thought you is also correct. So anyway, do you guys understand that? So
Yes.
6, 120, for everyone, just add 30. If you want to go Dr. Brunson's route, that's fine too. That's okay. On the board exam, if you can't find the answer with Dr. Bernstein, then use this one, and then you find your answer. Okay. All right. Does anybody know what a fructosamine is? Fructosamine? Anyone?
It's just a fructose sugar connected to an amine level.
Right.
And
So basically, it's the amount of fructose being bound to albumin. And basically, this is a faster way to tell the patient's blood sugar, right? So your A1C is the average of blood sugar in 3 months, right? Fructosamine is the average of blood sugar in 2 weeks. Okay, so if you are taking a patient for surgery, okay, and the A1C is, let's say, it's like 9, the recommended is has to be below 8, right? And patient is telling you, I'm losing weight, I'm eating properly, I'm better now, and you just want to check the level of their sugar, you can now use the fructosamine. Fructosamine will kind of tell you within 2 to 3 weeks what's the average of blood sugar. So that's a function of this, okay? The fructosamine. All right. It's not going to be on the exam. I'm just bringing it up just in case they ask you that question on your exit exam, not exit, sorry, on your residency program or board exam. At least you should know it. Fructosamine is a faster way of checking a patient's average blood sugar in 2 weeks as compared to 3 months, which is your A1C. Okay, but it will not be on the exam. Okay. That's okay. The next one I'm gonna go over is Charcot. So I finished PAD. I finished neurology. Now I'm going to Charcot. Okay. And also I did edema already. Also, edema is done. So when I'm done with Charcot, I think that's it. And then the last one is gonna be dermatology, which Dr. Shin is gonna cover tomorrow. To end my session, I'm going to ask you some questions at random to see if you guys are well prepared for the exam or you guys been listening to me. So Charcot, is Charcot an inflammatory disease or not an inflammatory disease? True or false? Which one? Is it inflammatory or non-inflammatory?
Inflammatory?
Beautiful. Inflammatory. Good job. Okay. So Charcot is a chronic progressive inflammatory disease due to neuropathic event. If there's no neuropathy, we don't have Charcot. Case closed. So the name that I love, I don't think we should be calling it Charcot. I think we should be calling it, inflammatory neuropathic osteopathy. That should be the best name for Charcot. Inflammatory neuropathic osteopathy. I say inflammatory because the first thing that happens is inflammation. Okay, you need neuropathy for you to have Charcot, right? And Charcot affects both your bone and your joints. So I think the best one should be inflammatory neuropathic osteopathy. Anyway, differential diagnosis for Charcot. Okay, there is something called atrophic Charcot and hypertrophic Charcot. Atrophic Charcot affects the metatarsal, and basically what you see is erosion of the metatarsals, pencil and cup, right? You see something like that. You can also see something called arthritis middlens, which is people. So basically, with a patient with atrophic Charcot, they could look just like someone that has a psoriatic arthritis. Okay, that's why it's very important that you get a really good history and physical. When it comes to hypertrophic Charcot is anything that's affecting the metatarsal past the midhead. So anything that's affecting the metatarsal past the midhead, especially the joints, the Lisfranc joint, the metatarsal joint, the ankle joint, your subtalar joint, and your calcaneus. But when you see erosion of the metatarsal heads, that's atrophic Charcot. So did Dr. Van Rugo go over this? French theory, German theory?
I don't think so.
She mentioned the two theories.
Oh, guys, I think she. I gotta watch the video. But listen, you have to know this. This will be on your exam. I'm telling you right now. You have to know this. They ask this question all the time in residency program and board exam. You must know this. Take a picture right now. I'll send you this this PowerPoint so you can review it. You must know this. I'm sorry. I know she discussed it. If she didn't discuss it, you must know it. Period. Okay. Neurovascular pretty much is a theory that was published in the French journal by a French guy. That's what they call it, the French theory. And they believe that what's really causing the Charcot is pretty much just soaking bone into water, soaking bone into blood, and that will cause the bone to just become very soft and it will just break down. So that's why in Charcot you have this aperemia, you have increased vasculature, to the area that's soaking in blood and making it break down. It's a theory. It's not proven. It's a theory. But they call it the French theory or your neurovascular theory, meaning that you have a combination of, aperemia and also neuropathy causing the breakdown of the bone. Then in the German theory, they talk about neurotraumatic, meaning that is a combination of nerve damage and trauma that is causing this problem. So they call it the German theory. Okay. The one that is widely accepted and that people are going towards to right now, they think that's really the reason why these people have Charcot is what's called the unregulated pro-inflammatory cytokine theory, or they call it immunocellular theory, or they call it pro-inflammatory cytokine theory. So do me a favor on your residency interviews, or when we go to externships, if they ask you what are the theories for Charcot development, you're going to say the French theory, neurovascular, the German theory, the neurotraumatic, and you're going to say the pro-inflammatory cytokine theory, or you could call it the immunocellular theory. Those are the three ones that is very, very important. And with your pro-inflammatory cytokine, it talks about excessive release of interleukin 1 beta, interleukin 6, and also tumor necrosis factor, excessive release of it, causing breakdown of bone. And I explain in a minute. Did she talk about this? The OPG rank system?
Yeah, I believe we had a slide on that.
Perfect. Good. So this is very important. So basically, the OPG, the rank and the rank and rankia and the rank. So the rank actually is pretty much how do I say, is the receptor. Okay, it's the receptor. So basically, whatever that bounds to it is going to express that. So if you look right here, this is your rank system right here. This is your rank system. Whatever that bounds to it is what's going to express. If the rankia bounds to it, okay, the rankia, what it does is to stimulate osteoblastic activity, meaning that it's going to cause bone breakdown. Okay, sorry, osteoclastic activity. So osteoclastic activity, I apologize. Osteoclastic activity is going to cause bone breakdown, rankia. If it's the OPG will stimulate osteoblastic activity and produce more bone. The way you remember this is OPG. The full meaning for OPG is called osteoprotegerin. Okay, osteoprotegerin. And the way I remember it is osteoproduction, osteoprotegerin. So OPG will produce more bone. OPG will stimulate osteoblastic activity, whereby rankiel will stimulate osteoclastic activity and cause bone breakdown. So whichever one that is bound to the rank system is what's going to be expressed. Okay. So there is something also called the calcium gene-related peptide. They call it CGRP. It's an antagonist to rankiel. Okay. So anytime you have increased production of calcitonin, remember calcitonin does what? What does calcitonin do? It maintains calcium, right? It prevents osteoclastic activity. You guys remember that calcitonin? Yes, agree?
Yes.
Right. So calcitonin gene-related peptide, what it does actually is to stimulate the production of OPG and antagonizes the rankia, prevents rankiel. So you need to know that too. Very important. You have to know that. Okay. So any questions about this? So let me give an example. A patient that's got osteoporosis, okay, do they have rankiel being bound to the rank system or the OPG?
Can you repeat the question?
A patient with osteoporosis, do they have more expression of rankiel or OPG?
Rankel.
That's right, rankiel. A patient that has something called osteoporosis. Remember that osteoporosis in medical imaging 1 or 2? One of them. Osteoporosis, when you have excessive production of bone, you're going to have this radio dense bone. So you have excessive production of bone. They call it marble bone. You guys remember that? Osteoporosis? Yes?
Yeah.
Yes.
Okay. So osteoporosis, do you have more expression of OPG or rankiel?
OPG.
Exactly.
Hello?
Okay. So right here, osteoporosis, okay, too much OPG, you get extreme dense bone. When you have Charcot, fractures, osteoporosis, you have more production of rankiel. Does that make sense?
Yes.
Okay, so let me give you an example, some sample question. You have a patient that have excessive vasodilation in the foot. The patient has neuropathy. What theory could lead to this patient Charcot?
The French theory.
That's right. You have a patient that's got neuropathy. He walks 80 miles a day. Unfortunately, the patient developed Charcot. What theory explains that?
German.
You have a patient that's got excessive production of rankiel, leading to Charcot destruction. What theory discusses that?
Immunomodulation theory.
Even though, Yeah, immunocellular theory, or they call it the pro-cytokine theory, pro-inflammatory cytokine theory, or they call it cytokine theory, whatever you want to call it. Does that make sense? Are we good? All right. For the exam, write this down. The only 3 classifications you're responsible for are your Anker-Holtz classification, the Sanders classification, right? And also the Chancellor classification. Everything else you're not responsible for. So you need to know that. Now, on the final exam, you are responsible for everything. But for this one, you're only responsible for those 3. Okay? Anker-Holtz, Sanders, and your Chancellor. Which one talks about MRI classification?
Angela.
Okay. True or false? A patient with dislocation and fragmentation on an X-ray is stage 1 Chancellor classification.
False.
Why?
Because it's on X-ray and on MRI.
Thank you. Thank you so much. Very important. Okay. So let's talk about Anker-Holtz classification. The one that's going to confuse you actually are the names. Stage 1, some people call it developmental, some people call it fragmentation. Okay. Stage 3, some people call it consolidation, some call it remodeling, some call it reconstruction. So you got to just memorize that, know those names, different names like that. Number 2 is very easy, coalescence. That's it. The original Anker-Holtz did not include stage 0. So it includes stage 1, 2, and 3. And with stage 1 is fragmentation and dislocation. So basically what you're going to see on the X-ray, you're going to see fragmentation and dislocation or subluxation. And the foot is going to be red hot swollen. Okay. At that point with stage 1, it's way too late. Right? Coalescent basically is a reversal of stage 1 where you have decreased swelling, decreased erythema, everything is getting decreased. Okay. And also what you see is absorption of debris and new bone formation, sclerosis. Okay. And stage 3 is consolidation or remodeling. And basically you don't have any swelling, you have no erythema, you have no nothing. And basically what you see most of the time, something called rock bottom foot, and the bone is really hard. Shimboda in 1990 talked about stage 0 of Charcot. This is where you have red hot swollen foot without no X-ray deformities. You have no fracture, no dislocation on the X-ray, everything was found on the X-ray, but clinically they have red hot swollen foot. And basically they recommend using infrared ray dermatomography. Basically it's a skin temperature. Basically we have downstairs in the clinic. And basically what you're doing is just measuring the temperature of the skin, okay? And you have to compare it to both limbs. So if you're doing measurement of temperature on the midfoot, on the condylar side, you have to do temperature on the same site. So if you're taking temperature of the MPJ on the right side, on the left side, you have to do temperature of that site too. The most important thing that you'll see is if you have 4-degree increase, okay, in temperature as compared to condylar, that's the definition of a patient possibly, having inflammatory condition, especially Charcot. Okay. Now, so in Shimboda, they said the best thing to do actually is to get an MRI on this patient. So the modality of choice to diagnose Charcot early is MRI. Because of MRI, you're going to see increased inflammation and edema. You're going to see microfracture, not macrofracture. Macrofracture, which is what you see on the X-ray. Microfracture is what you see on the MRI, just like a stress fracture, and you're going to see bone marrow edema. So on the exam, don't forget the best imaging modality, the best is your MRI to diagnose stage 0 Charcot. Okay. And obviously, PET scan actually is better than MRI. So if you see PET scan, they want to go for PET scan. But MRI is pretty much your choice modality, for diagnosing stage 0. Okay. So this is your Chancellor classification. Chancellor classification is very simple. You have stage A, okay, and you have stage 0 and stage 1. So stage A, and I love this classification, is it active or inactive? Okay. So if it's active, active is stage A. If it's inactive, it's stage B. Okay, or called B calm stage. Okay. Then it's severe grading, stage 0 or stage 1. Stage 0 is saying that on the X-ray, is it normal or abnormal? If it's normal, that's stage 0. In stage 1 on the X-ray, that means you have macrofractures. Okay, and that's it. Okay, so if they say on the exam, what is stage A0? So stage A0 means the A means it's active. So you have active Charcot, 0 meaning that the X-ray is negative. But on the MRI, you probably have bone marrow edema, microfracture, and bone bruise, or bone contusion. Any questions? Any questions?
No, sir.
No.
Okay, so these are different names. Prodromal period, which is stage 0, that's the name for it. Stage 1 called developmental. The name for it is called fragmentation. Stage 2 is always coalescent. Stage 3 is a problem. They call it remodeling. They call it reconstructive stage, or they call it consolidation stage. So you got to know that name. So again, know what you see. On stage 0, you're going to see red hot swollen foot with no X-ray finding. But when you do MRI, you're going to see a microfracture and on like that. What is the earliest sign of Charcot? Anyone?
The red heart swollen foot, painless.
Inflammation. That's right. You're right. Red hot swollen foot. Inflammation. Okay. How long does it take for you to develop Charcot? 4 to 6 months. Okay, got it. We got that. Okay. True or false? This is stage 1. Ankle holds. Why is it false?
Even rocker bottom foot. So here's
Rocker bottom falls. That's stage what? Stage 3, right?
That's right.
That's right. True or false? Rocker bottom foot is the late stage.
True.
True.
That's right. Okay. So again, if you look right here, you have this patient on this X-ray. It looks beautiful, no problems, great. But you can see that, swelling. You got a soft tissue swelling on an X-ray, right? Now look at this MRI. What do you see here? You see bone marrow edema. I don't see no fractures though, but I see bone marrow edema. So this bone marrow edema includes the medial cuneiform, includes the navicular. So to me, this patient is having Charcot breakdown in the midfoot. Does that make sense? Okay. So when you get this on the exam, this is your active stage 0 or stage 1?
Stage 1. No, stage 0. Sorry.
Stage 0, because on the X-ray, you don't see nothing. So that's active stage 0. Okay. All right. When it comes to Charcot, early Charcot, you want to do MRI to confirm your diagnosis. Okay. And you want to put them on total contact cast as soon as possible. So question, who wants to help me out? Let me call on someone to make sure we are on the same page. Claudia, are you here?
Hi, Dr. Sam, I'm here.
So Claudia, what stage of Charcot is this one? Ankle holds. It says that it's developmental, it's destructive, it's red hot swollen, you have a joint effusion, osteochondral fragmentation.
Stage 0.
Ah.
With the joint effusion?
Let's start again.
Okay.
The patient has developmental stage, destructive phase, red hot swelling foot, joint effusion, osseous fragmentation. What's your diagnosis?
Yes, I can hold stage 1.
Everybody agree or disagree?
Agree.
Wait.
That's right. Okay, next person. Let's see. What do we have here? Debbie.
Yes.
let's read this together, right? On a radiograph, you see, well, you see unilateral red hot swollen foot and leg. Normal radiograph with soft tissue swelling. What do you think?
Normal radiographs, like in terms of everything, or and
No,
not including deformities.
Radiograph is what? What is radiograph mean? What does that stand for? What does that mean?
An X-ray.
Exactly. So you have normal X-ray, but you have a red hot swollen foot. What stage of ankle is that?
0.
Okay. What stage of tantalus is that?
That would be active and the low impact.
So active 0, right?
Yes.
You got it. Is this good? Are you guys getting this?
Yes.
Okay.
Yes.
What's my friend? Oh, she's not happy, upset. Cindy, are you here? Oh, Cindy's
Here.
not.
No, I'm here, Dr. Sam.
Oh, Cindy, you got the bullet. Okay, so Cindy, let's read it together. Reconstruction. Bone hand and major fragment becomes rounded. Okay, you have bone consolidation. What's that?
Resolution. Stage
Right. Stage 3, right?
Yes.
Okay. Let me see. Where's my other friend? Olivia. She's always here though.
Hi.
Hi, Olivia. So what about this one? Coalescent phase. Osseous resorption. What stage is that?
Stage 2 Eichenholz.
That's right. Beautiful. Excellent. Okay. So basically, the most affected joint when it comes to this, when it comes to Charcot is your Lis franx. Okay. And basically what you see neuropathy, right? Couple that with increased focal pressure. Couple that with a very tight Achilles. Remember, when you have a very tight Achilles, you have more pressure in the midfoot and the forefoot, and that will lead to breakdown. And that's the reason why in Sanders and Freiberg's classification, the most affected joint, okay, is your Lis franx, number 2. That's the most affected joint. So in Sanders, stage 1, your atrophic. Stage 2, your Lis franx. Stage 3, your midfoot. Stage 4, your ankle. And stage 5 is your calcaneus. Okay. So Olivia, let me ask you a question, right? You have a patient that has got a red hot swollen foot, all right? They have no pain. They have X-ray that shows dislocation of the Lis franx joint. Based on Sanders classification, which one is this?
Sanders 2.
That's right, Sanders 2. Based on Ankerholz, which one is this? Red hot swollen foot, Lis franx dislocation. Is it
Stage
1?
1 because of the
Right.
dislocation.
That's right. So it's 1. Exactly. It's 1. Okay. Can I use Chancellor classification on this?
No, because it's not an MRI.
Beautiful. Excellent. Good job. What is the gold standard for treatment of Charcot foot?
Total
Total
contact.
contact cast.
If you don't have total contact cast, what else can you go for?
Could use like a cam walker.
You can use Ken Walker. That's right.
Prefabricated orthotic.
So there's something called Crow Walker. You guys know what that is?
Yeah.
Do you know what a crow stands for?
Charcot restraint orthotic walker.
Oh, you're so smart. Who's that?
It's still Olivia.
Oh, just Olivia. Oh, Olivia. Okay. All right. So, yes. So basically, listen to this. The first line is always total contact cast. Diabetic ulceration, total contact cast. Choco foot, total contact cast. You want to offload, total contact cast. Don't forget, board exam love total contact cast. That's your answer all the time. If total contact cast is not there, the next best option is something called crow walker, Choco restraint, orthotic walker. Okay. Another one that people use a lot is something called patella tendon brace crow walker. So they combine patella tendon and also crow walker together to give you maximum offloading, ability. So you can get a patella tendon brace crow walker. So number one is TCC crow walker. If you have patella tendon brace, fine. If they can't find all the stuff, then you can go for can walker. If they can't find can walker, you can just put them in a regular cast, BK cast, right? Can I use a Ritchie brace to protect a patient with shocker foot? Anyone?
No,
No. You know why? Because when it comes to Charco, right? Well,
you can't.
we're protecting the bottom, the foot bones. Your Ritchie brace, or most of these braces, they're called tri-lock braces, they are really good for ankle sprains. What they do is they prevent frontal rotation, right? So they prevent frontal rotation, okay? They prevent your ankle from moving side, left, right, frontal rotation, right? So your tri-lock braces, your Ritchie braces, your what else? Those braces for ankle sprains, they're not good for Charco. The only one that is really good for Charco, it might be a little confusing, is called the patella tendon brace. Okay, patella tendon brace actually could protect the foot. Okay, that's the only exception. Apart from that, there's nothing else. Okay, no other brace really protect that foot than the combination of patella tendon brace and a crow walker. So braces don't protect the foot when it comes to Charco. Okay. All right. Let me pick on someone. Almost done. Noran,
Dr. Sam.
is this Charco?
You can't tell just by looking at it. You need to have more like an H and P.
Oh, you're so smart. What if I tell you I elevate this foot? It stays red. I put it down. It stays red. What's your diagnosis?
Cellulitis.
I elevate this foot. It goes away. I put it down. The redness comes back. Patient is severe neuropathic.
Charcot acute.
I have a patient that has got a red eye swollen foot. He's got fever. The white count is 80,000.
Could be OM or septic joint.
So smart. I'll leave you alone. Okay, excellent. Good job. Excellent. Oh, no, Ryan, how do you use Sanders on this? What Sanders do you see here?
That looks like it's affecting the ankle and subtalar joint. So probably 4.
That's right. It's 4. That's right. You got it. Good job. It's 4. Yeah. Good job. Excellent. So again, blower you could order. You guys know this already. I don't go into depth about that. I'll let it go. I'll let that go. Okay. This is very important. With Charco, you're going to have a, low to normal ESR, low to normal CRP. You might get a little bit of high, sometimes you have a recent trauma. You might get a low to little high WBC. But if you have acute osteomyelitis, your ESR will be high, your CRP will be high, and your white count will be elevated. Based on literature that we talked about on Friday, what is the cutoff for osteomyelitis for ESR?
60?
70. But 60. So in the past, this is 70. But when you combine ESR and CRP together, it's pretty much 60. And what other number for CRP?
8?
Nope.
9?
7.9. So when you have an ESR of 60 or more and CRP of 7.9 or more, the combination of both, your chances of osteomyelitis is very, very high. Okay, that's how you use that. Okay. Can you use a bone scan, okay, to rule out Charcot? Yes. Bone scan, technetium bone scan could be used. WBC bone scan. What if I tell you, I could combine technetium bone scan and WBC bone scan together to differentiate between Charcot and osteomyelitis? True or false?
True.
Right. The WBC bone scan is more for the infection, right? Agree?
Yes.
Okay. Another thing that could use is something called technetium scan and a gallium scan. Okay. So basically, gallium scan is for soft tissue, whereby technetium for bone. So basically, when you have positive gallium scan and positive technetium scan, that's osteomyelitis. If you have soft tissue, positive gallium and negative technetium, that's cellulitis. If you have negative gallium and positive technetium, you have Charcot. So this is how you kind of use the combination of these bone scans, to rule out osteo from Charcot. Obviously, the best nuclear medicine is your PET scan. Okay, that's the best one. All right. Again, this is not going to be on the exam. Just FYI, there's something called, combination of the WBC bone scan and the technetium bone scan with sulfur colloid. Sulfur colloid is really used for, patients that's got a bone problems. Okay. Bone tumors and stuff like that. So when sulfur colloid is positive, you have bone issue. If WBC is positive, you have infection. So the best way, to do this is if you have a positive WBC, you have a bone issue, you have a infection. Now, if your sulfur colloid is negative, that means you do not, okay, have Charcot, then that means you have osteomyelitis. Again, you have to know this is more intense, more advanced. It's a recent article about this where you could use WBC bone scan and technetium with sulfur colloid to diagnose osteomyelitis and Charcot. So anyway, what I'm trying to say is that if WBC scan is positive and the technetium scan with sulfur colloid is negative, that's osteomyelitis. Charcot, when the TC sulfur is positive and the WBC is negative, that's Charcot. Again, another way to use a nuclear medicine to diagnose your problems. We discussed this in Medical Imaging 1, 4 phases of technetium, first phase, second phase, and third phase. When it comes to stress fracture, which phase will be positive? First, second, third, or all of it?
Can you repeat that?
With stress fracture, which phases will be positive? With stress fracture, first, second, third, or all of it?
All of it?
That's right. With patient with cellulitis, which one will be positive? First, second, or third? Or first and second, and not third?
I don't know, just the first and second.
So basically, with cellulitis, okay, what you're looking for, first phase, second phase is going to be hot. You can't really tell if you have cellulitis or osteomyelitis. You have no clue. You have no clue. But with the third phase, okay, which your delay phase, basically, that is really used for osteomyelitis, and that really differentiates between cellulitis and osteomyelitis. So your third phase, if you have a positive third phase, that's more like osteomyelitis and less more of cellulitis. Now, it can be a combination of both. Okay. Now, if you want to really find out, am I really dealing with osteomyelitis here? Is just a really bad cellulitis? Then that's when you're going to go to a fourth phase, which is a 24-hour phase. And with that will automatically diagnose you for osteomyelitis. So the best phase to diagnose osteomyelitis is your fourth phase. And the best way to do it is if the ratio of the 24-hour is increased more than one whole number, okay, more than the third phase, that's positive for osteomyelitis. Again, this was discussed already in Medical Imaging 1. I just want to reinforce that. You could use this to diagnose your Charcot or your osteomyelitis. Okay. Almost done. Oren, are you still here?
Hi, Dr. Sam.
Oren, let's do this together. This is one of my residency interview questions. I want to see if you're a resident already. If I want to see if I could take you to my residency program, right? So describe what you see. Clinically.
I see erythema on the dorsum of the foot, swelling.
Perfect.
The nail looks dystrophic.
Perfect. You're done. Perfect. Give me 5 differential diagnoses for this red hot swollen foot.
Cellulitis, gout. What else can I say?
Osteomyelitis, septic arthritis, things like that.
Osteomyelitis.
Okay. What if I take this patient has an A1C of 14, monofilament of 3 out of 10? What does that mean? Neuropathy, right?
Yeah, uncontrolled diabetic and yeah, definitely neuropathic.
Okay. So if I tell you this patient's got a A1C of 14 and neuropathy, now what's your diagnosis?
Charcot?
Active Charcot. You got to say active Charcot, right?
Active Charcot.
Right. Look at this x-ray. Do you see anything that is of a problem on this x-ray?
No.
Nothing. So what stage of ankle Holtz is this?
It would be stage 1. 0.
Why'd you say 1?
Because I was thinking that I got it mixed up that there's no x-ray showing up on 1, but that's really stage 0, right?
Right, stage 0, there's nothing on the x-ray. X-ray looks beautiful. It looks fine. No problem on the x-ray. Okay, got it?
Mm-hmm.
Okay.
I have a question.
Yes.
Is there a reason why the cuboid looks kind of fused with the cuneiform, or is that just the angle?
That's the angle.
Oh, okay, just checking.
That's the angle. Let me call my other friend. Shiley, are you here?
I'm here.
Good. Chantelot classification, can I use it here?
No, because you just see an X-ray here. There's no MRI.
Good. How will you treat this, Shiley?
I'll put them in a total contact cast.
Let us say your facility does not produce or don't have TCC. What else can you use?
I'll look into getting a crow.
Crow is too expensive. What else can you use?
Cam boot or maybe some type of below the knee cast.
Oh, you are the smart. Well, good job. Once you resolve all these problems, okay, everything is now saved. The patient now went from Charcot stage 0 to now the redness is gone, it's now stable. What device can you place the patient on?
Like an orthopedic device?
Yes.
Could you try a patellar tendon bracing?
You could do that. You could do a crow walker. You could put them on a well-padded diabetic shoe, right? You could do that. Good. What infusion therapy can you use to treat the Charcot?
Infusion therapy. Do you mean like bisphosphonates or something?
That's right. You got it. Bisphosphonate. That's right. Bisphosphonate, alendronate. That's right. What is the function of bisphosphonate? What did it do in terms of Rankia OPG?
Does it inhibit like osteoclastic activity?
That's right. You got it. So it stops the Rankiel. Beautiful. Last question. What is the best imaging modality to confirm your diagnosis?
MRI.
Oh my goodness. Beautiful. Okay. I think that's it for me. Okay. So that's it. I went over everything. I think I covered everything, right? Let me just make sure. I didn't cover dermatology because that's going to cover tomorrow. Did I cover everything?
Yeah, that's everything.
Okay. So what I want to do now is I want to ask some questions, just kind of make sure you guys guys get this, and we're going to end it. Is that okay?
Yeah.
Okay. And this is going to be like random questions to kind of see if you guys understand everything I just talked about. Okay. If you have a patient, okay, that has got a severe poor circulation and you're not sure what type of atherosclerosis is it, okay, and they tell you that this vessel that is really affected at the small and arterial vessel, what type of atherosclerosis is that?
Arteriolar.
Arteriolar, exactly. What is the best way to diagnose DVT?
D-dimer.
D-dimer.
Ultrasound.
Venous duplex.
Ultrasound duplex.
Who said D-dimer?
I did.
Why?
I was mixing it up with ruling out.
Okay. That's fair. Thank you. Credit to yourself. You almost have a heart attack right there, you know? Thank you. No, I'm joking. I just want to make sure we guys understand this. The best imaging modality is ultrasound, especially your venous ultrasound. Please don't forget that. Venous ultrasound, right? Your D-dimer is pretty much, is D-dimer the gold standard for ruling out a DVT?
Yeah. I'm assuming yes.
Tatiana.
Hello. Hi. Yeah, it's the gold standard. If the D dimer is negative, you don't have a DVT.
Shiley. What is Shiley? What does it mean to say gold standard? What does that mean?
Like the best way of assessing if you have it.
Okay. Thank you so much. You got it. So, Shiley, if you are suspecting a patient with DVT, what is the best imaging modality to rule out DVT?
Duplex.
Thank you. What is the gold standard to rule out DVT?
Duplex.
What is the screening test to rule out DVT?
I'm gonna say duplex.
D-dimer.
D-dimer. So there's a little confusion here. The only time you're going to order D-dimer is if you wanted to screen for DVT. Screening, right? But if you wanted to confirm, if you wanted to, if they ask you the gold standard, which is like the way to confirm something, your answer is what?
Duplex.
Venous duplex. So venous duplex is the gold standard to rule out DVT. The only time you're going to order D-dimer is if you just wanted to screen for it. But if you're in a clinic and you think that your patient might have blood clot, should I get D-dimer or should I get ultrasound?
If you have a high suspicion, you should get the duplex.
Just get duplex.
Right, get duplex. So just to make sure there's no confusion here, anytime you see DVT, your first thing that should come to your mind is venous duplex. Always venous duplex. The only time you're going to get your D-dimer, the only time is if you want to screen for it. Screening, okay, is not the same thing as confirming. If you want to confirm, the best test, also called the gold standard, which gold standard is what's really accepted by a lot of people, called gold standard, is your venous duplex. Any questions about that? Nathaniel.
Yes, sir. No question. Duplex to rule out or to confirm it's there. If
That's
you're
right.
just curious to check for it or not, D-dimers.
That's right. Okay. And if they use words like gold standard, what do you say? Is gold standard screening test or confirmatory test?
Confirmatory.
Yeah, it's confirmatory. It's pretty much what's really widely accepted. Gold standard meaning that what's really widely accepted. If I ask you, what is the gold standard for PAD? What's the non-invasive vascular study gold standard for PAD? What would you say?
ABI.
Anybody else?
What was the
Arterial
question?
duplex.
What is the gold standard? The best. Remember, gold standard is also the best, right? Gold standard is also what's really widely accepted. What is the gold standard or the most or the best non-invasive vascular test for PAD?
Arterial
Duplex.
duplex.
Arterial duplex. What is the gold standard for DVT?
Duplex. Ultrasound.
Duplex. What is the best test for DVT?
Duplex.
What is the best test for PAD?
Duplex.
Good. All right. What is the best invasive?
Angiogram.
There you go. Angiogram. Good job. Okay. Does that make sense?
Yeah.
How do you treat DVT?
Low molecular weight. Anticoagulant.
Anticoagulant or low molecular weight. Okay. Heparin. Okay. If I give you a ABI, and I want you to calculate ABI on the left side, okay, but the brachial pressure on the right side is what's higher. Can I still use that?
Yes. Use the higher brachial.
Good job. When it comes to your Charcot, right? If I say a patient has osteoporosis due to overproduction of OPG, what theory is that?
Cytokine theory.
Right. If I have a patient that has got a Charcot stage 1, okay, true or false, it's way too late to really arrest the disease.
False.
What if I tell you is late, not too late, but it's late, to treat the disease?
It's not ideal.
False.
False. So I say true. So basically, what they're trying to say now in literature is that I like what Jonathan just said. That's beautiful. That's a better way of saying it. Once you get to stage 1 of Charcot, especially ankle holds, it's not an ideal time to start treating it. It's not ideal. The best ideal time is stage 0. Okay, that's the best ideal time, stage 0. Okay, when it gets to stage 1, it's not too late, but it's kind of late because now you are dealing with a patient that's going to be out of work, going to be depressed. You have to put them in a cast for a long time and that sort of stuff. They might end up with a BKA. Okay. Okay. Good job. Dr. Bonarigo went over some other diabetic musculoskeletal manifestation. Can you tell me other things you could see in diabetic patient apart from Charcot?
Adhesive capsulitis.
That's right. Keep going.
Flexotenosynovitis.
That's right.
Purple tunnel.
That's right. That's right. What is a prayer sign?
They can't fully extend their fingers whenever they try to put their palms together. Like there's a space in between them.
What's the name of that deformity that you see or syndrome that you see in diabetes? What do you call it?
Limited joint mobility syndrome.
That's right. Good job. Excellent. Good job. Good job. Excellent. If you have a patient, by the way, again, I'm not trying to trick you on the exam. I'm not. I'm really wanting to test your knowledge. There's going to be some 3 questions on there that you got to pay a really close attention because the questions and the answers are so close. You can't really tell them apart, but it's one word that will tell them apart. For example, if I say, a patient, with acute limb ischemia, all the following is true, except, and I say, they have symptoms more than 2 weeks. That's wrong. So there's even more questions like that that's very subtle. So you have to read every single word. My recommendation to you is read every single word. Just don't think, oh, okay, the first is correct. Oh, that's the answer. Don't fall for it. Read everything. Okay. Trust me, after the exam, I always get to say, oh my God, I didn't see that because you didn't follow my instruction. Read everything. Don't jump to the gun. Okay. What is the best way to surgically treat a patient with acute limb ischemia?
Bypass?
The best way.
Embolectomy.
Embolectomy, or thromboembolectomy. Can you do bypass? Hell yeah, you can do bypass. But the first thing you want to do is get the clot out, remove the clot. Okay, so thromboembolectomy, and after, if you want to do bypass, fine. If you want to do fasciotomy, fine. Okay. A patient with calcified vessel, should I use segmental pressure?
No.
No.
Can I use exercise ABI?
No.
No.
Can I use your regular ABI?
No.
No. Okay. True or false? A patient with TCOM of less than 30 as PAD. Hello?
Can you repeat it one more time?
True or false? A patient with toe pressure less than 30 is PAD.
False.
True.
A patient with a toe pressure of less than 30 is PAD. True or false?
True.
True.
A patient with TCOM of less than 30 is PAD.
True.
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 A patient with SPP of less than 30 is PAD.
True.
A patient with TBI of less than 0.7 is PAD.
True.
Excellent. A patient with painful neuropathy as small fiber neuropathy.
True.
A patient with A alpha as motoneuropathy.
True. True.
A patient with C fiber neuropathy have autonomic neuropathy.
True.
True.
A patient with C fiber neuropathy, A beta neuropathy, have sensory neuropathy.
True.
True.
A patient with loss of vibratory sensation has sensory neuropathy.
True.
A patient, what? Who said false?
No, it was a mistake.
Okay. A patient with urinary incontinence has sensory neuropathy.
False.
False.
If you guys notice what I just did, I just asked you 15 questions based on that slide. Remember that slide I want you to read? Please make sure you remember that. Okay. If you have a patient that has failed multiple endovascular procedures, what is the next best thing for this patient?
Bypass.
What if the bypass failed? What is the next best thing for this patient?
EVA.
Oh, who said that?
Cat. I did.
Oh, Kat, good job. So, Kat, what are the indications for DVA?
Isn't it just when everything else fails?
That's right. That's right. Everything fails. What about the Rutherford classification?
Like 5 and 6?
5 and 6. What if the patient has a severe, extensive soft tissue damage? Can I use DVA?
Nah, you just have to amputate it.
Good job. Excellent work. Good job. What is the first vessel that comes off your papillary artery?
Anterior tibial.
Anterior tibial. Good job. True or false? Ipswich, Sams Weinstein vibratory could be used to check for loss of protective sensation.
True.
True.
True. Which one is the most sensitive? Reflexes or vibratory sensation?
Reflexes.
Which one is the most sensitive? Vibratory or monofilament?
Vibratory.
If you have a patient that's got a cramping pain in a right leg and you order your PVR is short, is wide, true or false? This is normal.
False.
False.
If you have a patient that has got a calcified vessel, patient also has DVT. Patient also have a bypass to that right leg. Can I use the ABI or segmental pressure to check for non-invasive vascular studies?
No.
Good job. You guys on fire. If I have a patient that has an ulcer to the plantar lateral foot, what branch of the PT supplies that area?
Lateral plantar.
That's right. If I have a patient with cramps in a leg and they have Ishikawa sign, young patient, what's your diagnosis?
Popliteal cyst.
If I have a patient on the angiogram, I see stenosis with the knee flexed, what's that sign called?
Scimitar.
Right. If I have a patient that Mohammed presented to me on Friday, this patient has gangrene of the toes, okay? And Mohammed said they did amputation on the patient. Is that the right thing to do on that patient? On a dry gangrene?
Dry? No.
No.
When you have dry gangrene, what do you do with it?
Revascularize.
Right. Or you can just leave it alone. It's not infected, but you can revascularize it. Once you revascularize it, what do you have to do next before you do amputation?
Like microvascular.
Check for microvascular circulation, right? Or just call the vascular doctor and say, can I see the angiogram? And if the angiogram is not going to the foot at all, there's no foot circulation with the angiogram, where should be the amputation?
Where you feel pulses.
Okay, so where should be the amputation? What level?
Wherever the microvascular says that there's circulation.
Oh, hear me out. You have a patient that has got a gangrene of the toe. The vascular surgeon went in and they opened up all the vessels. And post revascularization, you look at the tree, you notice that the papilla looks great. But just about the ankle, there's no more flow. So there's no flow to the PT, there's no flow to the AT, there's no flow to the PL, to peroneal artery, PA. Okay, where should be the best level of amputation on this patient with a gangrenous toe?
Up to the popliteal.
And what do you call that level?
BKA.
BKA. That's what I'm saying. BKA. Does that make sense what I'm doing? right?
Yep.
Okay, I'll give you another one. Again, this is based, by the way, on the exam, you're gonna see two names on there. Okay. Your classmates. You're gonna see your classmates' name on it. Just to let you know, I make no questions. I make no questions. Okay. Okay, you have a patient that's got a gangrenous toe. Again, I'm talking about Mohammed's the one that talked to me on Friday. Gangrenous toe. Now I want to do amputation after revascularization. I find out that my TCOM to the midfoot is less than 35. Should I do amputation at that joint or proximal?
No, you gotta go more proximal.
Exactly. Exactly. What if the TBI is 0.1? Should I do amputation of that big toe?
No.
No. So TBI will tell me my toes, my digits, position to the toes, right? But can I use the TBI to determine the level of perfusion in the midfoot?
No.
No. That's what they call it, toe brachial index. Toe brachial index. So if there's no toe, can I get toe pressure?
No.
Can I get TBI?
Nope.
So if I can use those microsecretary non-invasive vascular study, what other can I use to help me determine my local perfusion?
TPG.
I could do PPG. That's true. That's true. I could do PPG. That's true. Okay, what else can I use?
TCOM.
TCOM. I could use SPP, right? And the other one that's also very good is your infrared rate tomography. Will also tell you what level of amputation, where you should do your amputation. It will tell you where you have good blood flow, right? So if you don't have toes, you cannot use TBI or toe pressure.
Wait, what did you say the TBI was? You said if it was less than what number? Not to amputate?
If your TBI is abnormal, okay, and your toe pressure is abnormal, you can't do amputation at the top. You can't. You can't touch that top.
Why not?
Because it's abnormal. It's not gonna.
Oh, okay.
Because toe pressure is telling you your microcirculation to your toe.
Got it.
TBI is telling you about microcirculation to your toe.
Yes.
So if they're abnormal, you better not cut that toe. You better go proximal. But the question is, how proximal are you going to go? The TBI is not going to tell you. The toe pressure is not going to tell you. That's why you got to go into TCOM or your SPP. All right. And your SPP will tell you at any level. So if I do SPP, okay, at the toes and it's less than 30, amputate at the toe or not at the toe?
Not at the toe.
Exactly. If my TCOM at the, let's say, at the short parts joints is 140, can I go ahead and do my amputation at that joint?
Yeah.
No.
Who said no?
Oh, I said no. I guess I misunderstood.
I'm sorry. What happened?
You said 140?
Yeah. 140, yeah.
That sounds like a good number, no?
Is that normal or abnormal?
Normal?
Yeah, it's good. It's perfect.
So why would you amputate? I'm confused.
We're talking about level of amputation. The level of amputation. We're talking about the same patient, a patient with a toe gangrene.
Okay, I got you.
Where should you do amputation? That's what I'm saying.
All right, got you. Thanks.
All what I'm trying to say is that you could use your microcirculatory non-invasive vascular study to determine your level of amputation. That's what I'm saying. Make sense?
Yeah, thank you.
Okay. If I have a patient with gangrenous changes, rest pain, non-healing ulcer, what am I trying to tell you?
CLI.
That's right. if you have a patient, if you have a patient that has damage to the axons, what do you call that?
Exondemesis.
What about a patient who's got a partial damage to the nerve?
Neuropraxia.
Apraxia. So okay, good job. True or false? I could use ENG and NCV to rule out small fiber neuropathy.
False.
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 Katiana, this is for you.
Okay.
What is
Wait, sorry, Dr. Sam, can you what test did you just ask about?
I forgot.
For small fiber?
I forgot. I'm just talking on my. I don't know. What did I say?
Okay.
What was the question? I forgot. I'm just talking.
Nerve
I think it was EMG,
velocity.
NCV exams for small fiber.
For EMG?
It was the the NCV exams and the
Oh yeah. I said, can I use EMG NCV to rule out small fiber neuropathy?
Okay.
What's the answer?
False.
Exactly. Right. Exactly. So Katiana, what is Oming test?
Dorsiflexion of the ankle. It's used for DVTs. It's the clinical test.
Beautiful. Okay, let's play. Anyone? Which fiber am I talking about? Small fiber or large fiber? Okay, just say which one. Okay. Reflexes.
oh,
Large.
Large. Loss of light touch.
Small.
Oh, you gotta go study.
Large.
When it comes to loss of protective sensation, that is checking for what?
Large.
Exactly. All right. So loss of vibratory, what is that?
Large.
Loss of protective sensation is what?
Large.
Loss of proprioception is what?
Large.
Burning, tingling, pain is what?
Small.
Okay. Can I use a cast to offload a patient with a Charcot foot?
Total contact cast, yeah.
How about regular cast?
Didn't you say that?
No, it's too rigid.
Say it again.
I said no because it's too rigid.
Anybody else?
I thought you said you could use it if the other, like you didn't have the other things in office.
That's right. You could use it. Obviously, the best answer is your total contact cast. That's true. But if you can't find it, if you can't have access to total contact cast, you don't have the material for total contact cast, you could definitely go into, BK cast. You can get a can walker. You get a crow walker. Get a patella tendon brace. Patella tendon brace is the only one that you could use to treat Charcot, especially when you combine it with crow walker. The only one. Any other brace, forget it. Okay. If I have a patient that's got intermittent claudication, what is the best initial treatment?
Modify their life,
That's right, lifestyle modification.
lifestyle modifications.
Which one is better in protecting the heart in a patient with PAD? Aspirin or clopidogrel?
Clopidogrel.
Good. After revascularization, should I place a patient on a draw therapy?
Yes.
That's right. True or
On
false?
what therapy?
Draw antiplatelet therapy.
Dual.
Oh, dual. Oh, okay. Thank you.
Forgive me for my accent. Okay. What about statin? Can I use a statin to treat a patient with PAD?
Shouldn't you avoid that because of the statin myopathy?
No.
Isn't it protective for cardiovascular disease, but not PAD?
No. True or false? A patient with PAD should be placed on statins.
True.
True. True. So going back to Katiana's question, which is a great question. You should place a patient on statins, but if they develop statin myopathy, you should take him off statin and change it to a different statin.
Oh, okay. Thank you.
That's a great question. That's good. That's why we're here. Okay. So you never not want to put a patient on statin. You want to put them on statin because the statin will reduce the amount of fatty deposit in your heart and also in your vessel. So you want to put them on statin. You want to put them on aspirin to protect the heart. Now statin does not do anything for the ABI. It has nothing to do with ABI. Nothing. But statin has been shown to improve peripheral arterial disease and also CAD. Okay. A patient that's got a high blood pressure, you should place them on ACE inhibitor. True or false?
True.
True. Especially if they have PAD and high blood pressure. Okay. Pentoxifylline could be used for PAD. True or false?
Is it not FDA approved?
It's not FDA approved, but can you use it? Yes. Can you use it? Yes. So if the question says, which of the following is the best, right? And they put pentoxifylline and silazazole, which one will you pick and why?
Silazazole because it's FDA approved.
That's right. If they say which one is the current guideline, silazazole. But if they say which one can you use for intermittent claudication, and you can't find silazazole, and you see pentoxifylline, that's the answer. Okay, so just gotta be careful. Okay, with those kind of questions. Okay, Cheyenne, this question is for you. You have a patient with an ABI of 1.12, 1.12, 1.12. Okay, normal, abnormal.
Normal.
Okay. What is the next test for this patient?
Exercise ABI.
Good. Excellent. Do you guys remember how to calculate the segmental pressure? 20, above 20 is mild, above 30 is moderate, and above 40 is severe. You guys remember that?
Yes.
Okay. What is May-Turner syndrome?
The right iliac is compressing the left iliac vein, and it's compressing the left iliac vein.
The left iliac vein is compressed between L5 and the right
L5, yeah.
artery.
That's a better way of saying it, yeah.
Is it the common iliac or the external iliac?
Common.
Right common iliac artery.
Okay. True or false? May-Turner syndrome could lead to venous insufficiency.
True.
Okay. Let me see. Acute on chronic, right? What is the number one culprit? What really caused that? Acute on chronic.
PAD.
It's a PAD, that's true, but what? Is it caused by thrombus or embolus?
Embolus.
Thrombus. Embolus is true CLI. Okay.
Thank you. Embolus is true acute limb ischemia. Thrombus is for acute on chronic. Do you guys remember that? Remember, people with acute on chronic, they have history of what?
History of PAD.
That's right. So people with history of PAD, what really happens is that, the vessel becomes smaller and smaller and they develop stasis. When you have stasis, you're going to develop thrombus. So thrombus is for acute on chronic, and patient without no history of PAD is your emboli. It's a true acute limb ischemia. Are we good? So can you tell me different things that could lead to compartment syndrome?
Trauma, infection, acute limb ischemia.
Anything else?
Revascularization.
Okay, and then revascularization after acute limb ischemia, right?
Yeah.
Okay, anything else?
The blue venous one, I don't remember the French name.
Phlegmasia cerulean dolens.
Yes.
Okay, anything else?
Infection.
Infection. Good, excellent. I think I've answered all the questions. I think I went over all the PowerPoints. I think I covered everything. I think this is a really great session here. We're able to go back and forth and answer everything. Any questions so far? Do you think this review session helps you out a little bit? Does it, clarify everything?
Yes, this is very helpful.
Okay. Again, you have to remember in medicine, our job, again, my exam, you'll find out on Tuesday, my exam is not to get you. I don't want to get you. I want to make sure that can you answer a clinical question? If you could answer a clinical question and you understand the material, you're going to get 100. If you memorize, you're going to fail. I promise you're going to fail. So it's very important to me that you understand the material. If you understand the material, you're going to pass. You're going to do really, really well. On that note, if you have no other questions, Dr. Sheen will go over dermatology. To be honest with you, dermatology, you gotta just study. Unfortunately, you have to memorize it, unfortunately, and just understand a little bit, but it's a lot of memorization. I just recommend that review your material, very well on Monday, know it very well, and call your classmates and go back and forth and answer some questions. And I think you're going to be fine. Any questions for me?
Thank you very much, Dr. Sam.
Thank you, Dr. Sam.
Okay.
Sorry, Dr. Sam, what did you say leads to venous insufficiency?
May tunnel syndrome. May
May
tunnel
tunnel.
syndrome,
Okay.
when you compress that left common vein, that could lead to venous stasis. It could lead to venous insufficiency, DVT, and stuff like that.
Got it. Thank you so much.
All right. Listen, I wish you guys good luck on Tuesday. Don't forget, the first group, they got an 89 or 90 average. So let's see what you guys are going to get. Okay. Good night.
Thank you, Dr. Sam.
Thank you.
Record.